up. Okay, look at Dr. Betty's here. So this is, look, I am late to the party and I am really excited to have all of you here. It is 11:01 in Washington, D.C., where I'm joining. We're going to see where everybody is joining from lately. I am so excited. My name is Dr. Rami Azuine. I'm the lead faculty here at the Public Health 360 program, where we are shaping and training the next generation of public health practitioners who will go on to address health disparities, who will go on to address social determinants of health. So our program enrolls students from all over the world, put them through a 3 months intensive programming, and then after that, they go on to do exciting things. We have two key deliverables in the program. One is that the fellows work in very small groups developing a community outreach and education project, which they deliver across the world. And we have participants joining the program from all over the place. And then after that, on the graduation day, they also design a shovel-ready intervention program to be implemented to address a particular public health problem. We don't know. We have no idea what these are. We just present them with cases, and they go on to design these programs that we hope are shovel-ready to be implemented in developing countries or any other place. So we are so excited. Today is our culminating experience. So each of the fellows that we see today, they have passed through the crucibles of this learning, and they know that I'm usually not this nice, right? I'm not really usually this nice during the program, but we're gonna see. Today is an exciting day for me. I get to sit back, allow the global community to see what they have produced, sit back and listen, so we're excited. Brown, can you pull up the agenda, please? All right, next one. All right, so this is how we're going to run things today. Am I welcome? I have welcomed all of you. Thank you for joining us. For our fellows who are joining, thank you for joining us. And I'm incredibly indebted to Dr. Elizabeth Armstrong Menser, who's joining us from Georgia State University. She'll be excited about some of the projects because she is an expert in designing programs for developing countries. So we're going to hear her talk. Then the next thing we're going to do will be the faculty will introduce themselves. I'm the person that speak more, but this program wouldn't be successful were it not for the combined effort of all our faculty and staff. So they're going to introduce themselves. Then we go on to introduce our fellows. Our fellows are from across the world. Their names are listed in last name alphabetical order. When they introduce themselves, they're going to tell us where they are joining from to give you an idea of where in the world they are coming from. And then we are going to open the virtual floor with an introduction of our graduation speaker. And then after her talk, we're going to go straight into the capstone presentations. We're going to have group one. They have designed a program that they call the Pink Shield Project, addressing breast cancer in Lagos, Nigeria. Group two is going to take on, Group two has designed Mind Forward Accra, MIFA, an early intervention mental health program in Ghana. And then group three is going to wrap us up with Diabetes Free Karachi in Pakistan, a program to decrease type 2 diabetes in Karachi in Pakistan. So you can see the remit of the programs from West Africa, from Nigeria to Ghana, and then to Asia, specifically in Pakistan. For the first time this year, we have introduced an award where we are going to provide the best capstone award to the group that we have determined has presented the most innovative, the most culminating capstone project. And the team, the faculty are going to do the scoring. I have decided to recuse myself from it, right? In order to avoid conflict of interest. But the faculty, four of them are going to independently score, and Dr. Zubi is going to give us the person, and then we will announce the winner. Then we're gonna have our closing remarks, where we are going to give opportunities to the fellows to share their experiences. You know, we have guests, we have alumni fellows who have joined us. You know, they can also share their thoughts. You know, towards the end, it becomes a little bit, you know, sentimental and emotional, because that's when, after 3 months, we are going to say, you know, goodbye to each other. However, this group, we're excited that we are going to be introducing a LinkedIn group where we are going to continue the innovative work and bring together about 120, 150 people who have passed through this program over the years. So we're excited. We are excited. All right. So use the chat and tell me, I am ready. Are you ready for today? Use the chat and tell me, I am ready. Type in there, I am ready. I want to see who is here. Thomas Gunn is ready. Comfort is ready. Sarah is Martha is ready. Brown, please mute. Lucas, Sarah is ready. Hannah is ready. Julie is ready. Munawara is ready. Ernest is ready. Unity is also ready. Very good. I want to hear that. Okay. For Chanel, thank you so much for joining us. You are ready. You know, I made a post on my LinkedIn and I said this is a festival of excellence, right? And I got over 1,000 people, you know, reading that, because I say, come and just enjoy yourself. This is free opportunity, and this is the power of what training and development can do. I am excited about each of these fellows, what they are going to do in different parts of the world and in their careers. All right. So Brown is the faculty ready. And this is me here, right? You see me, I'm always smiling outside, but inside the class, I am not smiling, right? I'm very tough. I'm very, you know, I have this tough love on on the fellows. I push them hard. I tell them no. I think most of them for the first time is in this program that they hear people telling them, no, this is wrong, right? Because we are a society that says, it's not, no. Here I say, no, this is not right. No, this is incorrect. And they get to bear it for 3 months. But look at what they have produced. All right, that's me. Next, please. So I want to say a little bit about myself. Some of you know me, some of you don't know me. So I have a rich background in public health. I have my master's, I have my doctorate, I have nearly 20 years experience practicing public health across the world. I have worked in Europe, I have worked in Africa, I have worked in the United States at the highest level of biomedical and public health research. So I see, after doing all this 20 years career, I see that the next step in my career is to pour into the next generation, is to share everything that I have learned, is to share even my mistakes, things that I had regretted, just to make sure that they do not make the same mistakes as I made. To give them everything that I have so that they can look forward to creating a career. Number one. Number two, I hear a lot of people reach out to me and say that they have finished their courses in public health and they could not get jobs. Public health is dead, and I'm telling them I don't think so. What has changed is the approach, right? You have to come to the table with a lot of skills. If you don't have the skills, the employers are not going to hire you, because employers are looking for somebody to solve problems. And so I think we can correct that. That's why we created this program, and we have seen diversity. We have seen growth. We have seen inspirational work that people are doing, both as NGO workers, as a business, consulting business in public health, as individuals who have improved their own careers. And that's why we're fortunate that more and more students are coming back to RAS. Okay, so we're going to start introduction. I'm going to begin with Brown, because he was the person that was here the most. Brown, unmute, get on camera, and introduce yourself.
Thank you, Dr. Romy. So my name is Brown Magnus Olivers, and I'm the IT and outreach coordinator. I'm also a faculty supporting PhD fellows. Thank you, Dr. Romy.
Thank you so much. Thank you so much. We couldn't do this without Brown. Brown recently completed his master's degree in server services, computer science, something like that. So we are grateful. All right, who else do we have? Dr. Zubi, are you there?
Yep, I am here. I'm super excited. Welcome, everyone. It's good to see everyone smiling. Beautiful faces everywhere. We are so excited for this day. My name is Dr. Nzube Eboluche. I am the fellowship director. All of the students who are here today are here because they passed through a smooth enrollment and they had a great experience joining the program. So that's why all of them are here smiling with their beautiful faces, and we are happy to see what they've all achieved within these 3 intensive months. Thank you, and we are here to hear what you guys have to say. Thank you.
Thank you so much, Dr. Zubi, for providing incredible experience to our students from the time they reach out to us, the time they enroll, and the time they are onboarded in the program. Thank you for your work. Okay, Dr. Susan, is she there?
Yep. So thank you, everyone. My name is Dr. Suzanne Ekejuba. I see faces like Dr. Murillo. Nice to see you. You keep coming back. I'm the program director here at Global Health and Education Project. I walked through all your hard work trying to put things together, trying to put your capstone together, and I've seen that you are ready to give it all. So I'm happy to be here to listen to what you have to say today. Thank you, everyone.
Thank you so much, Dr. Susan. For the first time, we introduced a course, a gentle introduction, data science for public health. So we learned from that experience. We got a gentle introduction to data science, and I'm hoping in the summer session, we are even going to finesse it with the feedback that we got from this cohort. That is something that a lot of people have really asked us for. So Dr. Susan is a veterinarian turned pharmacologist turned project manager turned data scientist. Thank you so much for your work. And you saved the best for the last. I also have Dr. CJ Eboluche. Dr. CJ, are you there?
I believe Dr. CJ is in transit. Is he here?
No.
All right, we're gonna get to him. We're gonna get to him. But the key here is to let you know that when you are in this program, when you are joining this program, that you are going to be mentored by a diverse team. Diversity in terms of educational experience, diversity in terms of personal experience, diversity in terms of professional experience, diversity in the practice of public health and public service. So each of us bring our experiences. We all bring our mistakes. We all bring our regrets. And we share them with you in a way that you are going to be readier, that you are going to prosper more than any one of us had done. So that is really the goal. And that's why I'm excited about each of us. We come from different backgrounds, practicing public health in different realms. Next slide. All right, and this is the times of the day. So we're going to have them introduce themselves. We're going to have full introductions, during the project, but the goal here is that each of the fellows is going to introduce themselves, tell us where they are coming from, tell us a short background, and tell us where they are joining us from. Beginning with Afrin, Sheikh Afrin. All right, moving on. Comfort Ayavga.
Hi everyone, my name is Comfort Ayavga, Public Health Fellow 360. I'm joining from Boston, United States.
Thank you for being a good role model. I understand Sheikh is unwell, but hopefully she can join us. All right, next is Sarah Biola.
Good day, everyone. I'm Dr. Ayeni Sarah Biola. I'm a medical doctor by profession. I stay in Abuja, Nigeria, and I'm a PH 360 fellow. Thank you.
Unmute yourself, Dr. Rami.
Sorry. we have Sarah Ketsby. Sarah, over to you.
Good evening, good morning, everyone. My name is Sarah Catesby. I hold a BSc in Healthcare and Health Science, and I'm presenting myself from London. Thank you.
Thank you, Sarah. Next, we have Dr. Unity Doki. Unity, come on.
Hi, everyone. My name is Dr. Unity Dokifa, an ophthalmologist and a Public Health 360 Fellow. I'm joining from Monrovia, Liberia.
Thank you, Unity. So if you have eye problems, we have the doctor in the house. Next, we have Miriam Abraham. Miriam, are you there?
Yes. Yeah. Hello, everyone. Nice to meet you all. This is Mariam Ibrahim, a medical student from Egypt, and nice to meet you all. I'm a public health BH and 360 public health fellow from Global Health and Education Projects. Thank you so much for being here.
Incredible, Miriam. Miriam, where are you now? Are you in Dubai or where? Where are you?
Kuwait. Yeah, I'm in Kuwait right now.
In Kuwait. Excellent, excellent. All right. Next, we have Hannah Zaina. Hannah, over to you. Unmute.
Hello, everyone. My name is Hannah Zaina. I'm a registered nurse by profession. I'm from India, and I'm joining from Dubai, UAE.
What is the temperature in Dubai, Hannah, right now?
Right now, it's 40, I think.
40, that's about 90, right? Fahrenheit, right? Dr. Murillo, you do the math for us. All right, next we have Julie Herr. Julie, where are you? Unmute and introduce yourself.
Hi everyone, I'm Julie Herr and I'm an undergrad student and I am part of PH360 Fellowship and I am joining from California.
So every cohort, one of the things that Dr. Zubi does in consultation with all the faculty is to give an opportunity to an undergrad. You can imagine the entry-level position, entry-level qualification for the program is at least an undergraduate degree. And I can say that the program historically have had people on the upper side, you know, masters more, some people multiple masters, some doctorates. And so when you have an undergrad in the program, it could be overwhelming. So we select once in a while, we select one undergrad and give them the opportunity to immerse themselves within, you know, within a group of other physicians, of other experienced individuals. And Julie has been incredible. Julie is brave. So she was the brave soul for this spring 2026 cohort. So my hat's off for you, Julie. Next, we have Ernest Ike. Ernest.
Hi, everyone. My name is Ernest Ike. I'm a statistician by profession and also a fellow of Public Health 360. I'm joining from Abuja, Nigeria. Thank you.
Thank you so much, Annex. I really appreciate it. Next, we have Dr. Munawara Mohammed. Munawara, where are you? Where are you, Munawara? I want to see your face.
Hi. Good evening, everyone. I'm Dr. Munawara Mohammed. I'm a Public Health 360 Fellow. I am a medical doctor by profession, and I'm joining from Nairobi, Kenya.
Thank you so much, Doc. Next, we have Dr. Maria Chinyerem Onyekane. Where is she? Sister, where are you?
Hello, everyone. My name is Maria Chinyerem Onyekane. I'm a material scientist by profession. I am a public PH360 fellow. I'm joining from Maryland, USA.
Fantastic. Thank you so much. You can see we have everything here, right? We have 2 nuns in the cohort for the first time ever. We have 2 nuns in the cohort. So we're excited. All right. Next, we have Bushra Rahim. Bushra, where are you?
Hello, everyone. My name is Bushra Rahim. I'm a physiotherapist by profession, and I'm a PH360 fellow. I am joining from Pakistan, Islamabad.
Thank you so much, Bushra. Bushra always joins us like 2 a.m. in the morning, right? So 2 a.m. in the morning, and she's still there, and she's on camera. She's pushing, which is incredible commitment to the program. And always you save the best for the last. Where are you, Temesgen Tariku? Temesgen, where are you?
Okay. Good morning and good evening, everyone. My name is Temesgen Tariku Chifao. I'm joining from Washington, Seattle, United States, and I'm a senior care manager in profession, and I'm Public Health 360 Fellow. Thank you so much.
Thank you, Temesgen. So you can see, ladies and gentlemen, that our fellows come from diverse personalities, diverse professional preparation, diverse parts of the world, diverse experiences, but they are all united by one thing, that they all believe in addressing health disparities in global health. And that's why they are here. And we're going to see what they have created, and we're going to bid them farewell as they move on to the different parts of the world where they are going to go and transform the world. So please use your react button in Zoom and let us give our fellows an incredible, show them love. I'm going to use hearts. Feel free to use more than one. I'm using hand clap, I'm using love, and I'm using, confetti as well. Incredible. I couldn't tell you how hard each of them have worked. How hard in the timing, in the extra work, in the assignments, in the design of the program, in carrying other people forward. I am so proud of our fellows, and I'm so proud of the investment, and that is what I tell them, investment in their careers that they have made. 3 solid months of investment. All right, Brown, next slide. All right, this is the beautiful one. So our graduation speaker for this is incredible. This is the first time we're having ever somebody from a major university serve as our graduation speaker. So before I even introduce Dr. Armstrong Mensah, let us show her some love. Boom, heart. Good. All right, all right, all right, all right. So I am so honored to be introducing our spring 2026 graduation speaker, Dr. Elizabeth Armstrong Mensah. She is a clinical associate professor and undergraduate programs director in the Department of Health Policy and Behavioral Sciences at Georgia State University School of Public Health, GSU. She teaches both at the undergraduate and graduate levels. She is dedicated to advancing excellence in public health, excellence in research, excellence in practice. So the work we are doing at Public Health 360 is really aligned with her professional interests. Dr. Armstrong Mensah holds a doctoral and master's degree in international affairs and development. She has a bachelor's degree in sociology and has several professional training and development certification, as well as an expert monitoring and evaluation advisor. With over 25 years of experience, her work spans global health, HIV, water and sanitation, gender issues, health equity and disparities, maternal and child health, program management, capacity building, training, as well as development and design of instructional curriculum. Her extensive experience includes key roles as a health scientist at the Centers for Disease Control and Prevention, CDC, at the Center for Global Health, at ORISE Evaluation Fellow at CDC's National Center for Environmental Health. She's also a subject matter expert. She's also a global health track coordinator at Morehouse School of Medicine in Atlanta, as well as an instructor at Emory. She has been everywhere that you talk about, all right? So she also has been the National Program Officer for the United Nations World Food Program and head of the Training and Human Resources Development at the Training, Research, and Networking for Development Group. Dr. Mensah is the author of lecture notes, Global Health Issues, Challenges, and Global Action, published by Wiley and Sons, really, really well read. A British Medical Association nominated and highly recommended global health textbook, right? This textbook, check it out, purchased, sold, read. So she has also authored 2 book chapters, more than 50 peer-reviewed publications, and 13 training materials and trainer guide. Her research interests include HIV, global health, health inequalities, maternal and child health, and she serves as a peer reviewer for many journals, including BMC Public Health. A committed academic leader, Dr. Armstrong Mensah is the founder and the chair of the Georgia State University School of Public Health Research and Publication Club, the Meta Meet and Talk series, and the GSU School of Public Health International Students Club. She also serves as the director of the Georgia State University Study Abroad program and field study of contemporary global public health issues, which focuses on water and sanitation issues, as well as HIV and women's health. Her excellence in teaching, innovation, and service has been globally recognized. She received the GSU School of Public Health Excellence in Instruction Award, the Association of Schools and Programs of Public Health Early Career Teaching Excellence Award, and SHE Global Achievers Award for Most Innovative Study Abroad Program in West Africa. She is also a recipient of Africa's 100 Most Influential Women in Academia Award and the Georgia State University School of Public Health Excellence in Service Award, which was really received this year, and we are only 5 months in the new year. So, ladies and gentlemen, friends, brothers, join me to welcome Dr. Armstrong Mensah, our graduation speaker for Spring 2026 cohort.
Thank you very much, Dr. Azwini. I'm excited to be here this morning. So good morning, distinguished faculty, honored guests, mentors, family members, and most importantly, the graduation cohort of the Public Health 360 Fellowship. Today, we gather not simply to celebrate the completion of a program, but to recognize the emergence of leaders, individuals who have committed themselves to advancing health equity, strengthening education systems, and transforming communities across the globe. It is both a privilege and a joy to stand before you on this momentous occasion. Graduates, take a moment to reflect on where you began. Each of you entered this fellowship with a spark, a curiosity about the world, a concern for inequities, and a desire to make a difference. Over the course of this journey, that spark has been refined into something far more powerful: knowledge, resilience, and purpose. The Public Health 360 Fellowship has not been a passive experience. It has challenged you to think critically about the structural determinants of health, to question long-standing assumptions, and to integrate interdisciplinary perspectives into meaningful action. You have explored global health not as an abstract concept, but as a lived reality shaped by policy, culture, education, economics, and the environments in which people are born, grow, live, work, and age. You have engaged with complex issues, health disparities, access to care, education inequities, emerging global health threats. You have done so not from a distance, but with empathy and intention. You have learned that the greatest challenges in public health are rarely solved in isolation. They require collaboration, humility, and a willingness to listen. And perhaps that is one of the most important lessons you carry forward today, that impact is not measured solely by what you know, but by how you apply that knowledge in service of others. In global health education, the stakes are profoundly human. Behind every statistic is a story: a mother seeking care for her child, a student striving for opportunity, a community navigating barriers that many of us may never fully understand. Your work moving forward will intersect with these stories. And when it does, I encourage you to lead with compassion as well as with expertise. You are entering a world that is both deeply interconnected and undeniably complex. We are witnessing rapid changes in technology, shifts in global health disparities, and ongoing challenges, from pandemics and climate change to educational disruptions and system inequities. These challenges may seem daunting, but they also present extraordinary opportunity. An opportunity for you to shape the future, because you are not just graduates of a fellowship, you are part of a global network of change makers. Through this program, you have developed more than technical skills. You have cultivated leadership. You have learned to analyze, to communicate, to advocate, and to act. You have worked across disciplines and cultures. You have faced uncertainty, and in doing so, discovered your capacity to adapt. You have learned that public health is not just about systems and policies, it's about people. These are not small achievements. As you step beyond this fellowship, I'd like to offer you 3 reflections to carry with you, 3 guiding principles that may help you navigate the path ahead. First, remain grounded in purpose. There'll be moments in your careers where progress feels slow, where systems resist change, and where the impact of your efforts is not immediately visible. In those moments, return to your why. Why did you choose public health? Why did you commit to global health and education? That purpose will sustain you when outcomes are uncertain and challenges are great. Second, embrace collaboration. No single individual, organization, or discipline can solve the challenges we face today. The future of global health depends on partnerships across sectors, across borders, and across lived experiences. Continue to build partnerships. Continue to listen. Continue to learn from those whose perspectives differ from your own. In doing so, you will not only strengthen your work, you will strengthen the impact of entire communities. Third, lead with integrity and humility. Leadership in public health is not about authority. It's about responsibility. It's about recognizing that the communities you serve are the true experts in their own lives. Approach your work with respect. Acknowledge that you don't know everything. Acknowledge what you don't know, and remain open to growth. The most effective leaders are those who are willing to learn continuously, even as they lead. Graduates, today is both an ending and a beginning. It is the culmination of long hours of rigorous discussions and meaningful engagement, but it's also the starting point of a lifelong commitment to advancing health equity, to expanding access to education, and making systems more just and inclusive. As you move forward, remember that impact not always your impact will not always be immediate or visible, right? Change in public health often unfolds gradually over years and sometimes even over generations. But do not underestimate the significance of your contributions. Every program you design, every policy you influence, every community you support, these efforts ripple outward in ways that matter deeply. And while your professional journey is important, I also encourage you to take care of yourselves along the way. Public health work can be demanding. I'm sure most of you know this. Very, very demanding. It can be emotionally taxing. It can require you to confront difficult realities, protect your well-being, celebrate your successes, no matter how small, and find joy in the work that you do, because that joy is what is going to sustain you in the long term. To the families, mentors, and supporters present here today, thank you. Thank you very much. Because you see, your encouragement, patience, and belief in these graduates have been instrumental in their success. This moment belongs to you as well. And to the graduating cohorts, this remarkable group of fellows, I leave this with you. The world does not need perfection from you. It needs dedication. It needs your courage. It needs your willingness to show up, to engage, and to act. You've already demonstrated that you are capable of rising to the challenge. Now, it is time to carry that commitment forward to your communities, to your organizations, and the broader global health landscape. You are ready to advocate for those whose voices are unheard, ready to challenge inequities and reimagine systems, ready to build a future where health and education are not privileges, but fundamental rights for all. As you leave this fellowship, do so with confidence in your abilities, pride in your accomplishments, and a deep sense of responsibility to the work that lies ahead. Congratulations, class of the Public Health 360 Fellowship. Your journey continues, and the world is better because you are in it. Thank you, and thank you.
This is awesome.
I just want to allow that to sit for a minute. I want to allow it. I want to hold space for her and allow that to sit and allow you to react the way you would like to react. Thank you so much, Dr. Armstrong-Mensah. Exciting. I mean, exciting. You know, I need not say anything further. The three key principles: be guided in purpose, embrace collaboration, lead with integrity and humility. Those are powerful parting words for you. No matter where you are, no matter what role you're playing, no matter what position you are in. 3 key core principles. All right, so if you are really happy, let me see you in the message. Say, thank you, ma'am. Thank you. Thank you. Let me see you type, thank you.
You're welcome. The pleasure is mine.
Thank you so much. Thank you. Really, really, truly appreciate it. Okay, so I'm excited. You know, one of the things we talked about was I have a dream that one day we are going to have a cohort of PA 360 go to a country and study abroad. Maybe a partnership with Dr. Armstrong-Mensah might make that a reality. But keep dreaming, Dr. Romy. That's what some of you would tell me. So we keep dreaming, right? You never get what you didn't dream about. So dream is always the first beginning. All right, Brown, next slide. We are here, right? You know where we are. I am here. That's my email, my direct email. Dr. Susan is there, her direct email. You all know Zubi. Zubi is here. You know, Dr. Judith is there. Brown is there. Please do not be strangers to Public Health 360. Do not be strangers to GHEP. We rely on your support. We rely on your donation. We rely on your reviews. We rely on your word of mouth. You know, refer to other people that you think might benefit from this program. You know, do not forsake us. Each of you received some part of a scholarship. Help us to keep those scholarships flowing so that we continue to give people the opportunity to participate in this program regardless of where they are. If you are based in the US and you paid that little high amount of money, that is also your contribution to ensure that those from developing countries were able to participate in the program. And we say, thank you so much. Do not be a stranger. There are more things coming for this fellowship. And Dr. Mensah charged us today. She said, embrace collaboration. We cannot do it alone. We have to come together as a community, and you're going to get more information upon graduation. All right, Brown, next slide. Thank you so much. You know where to find us. You know, please follow us on LinkedIn, on Facebook, on Twitter, on YouTube, anywhere you know you are on. If you're on LinkedIn, we recommend that everybody should be at least on LinkedIn, right? That is the professional network, and every other one is an addition. But we recommend that primarily every public health practitioner should be on LinkedIn. You know, so once you're on LinkedIn, Follow each other, follow me, follow GHEP website, follow the journals, and ensure that you are beginning to create authority because you are now authorities in global health. Next slide. All right, Brown, we are going for the first group, right? We are going for group number 1. Let me see where that my agenda is to make sure. All right. All right, group number 1. Group number 1 is going to be presenting to us the Pink Shield Project in Lagos, Nigeria, a program to address breast cancer in Lagos, Nigeria. All right, thank you. So they're going to have 20 minutes to present. At the end of the presentation, we are going to open it up for questions. Do not wait. Use the chat. You can use the chat to enter your question, and then after, we are going to open it up. So, we can have questions, we can have comments, we can have feedback, because these programs are being developed for us. And hopefully we're going to implement these programs one day. All right, group 1, Brand, enable them to be able to share.
Good morning, everyone. Can you hear me?
We can, loud and clear.
Okay. Good morning, everyone. My name is Bashar Rahim, a PH360 fellow joining from Pakistan. And our team will be presenting the Pink Shield project based in Lagos, Nigeria. It is basically a 24-month blueprint to combat breast cancer mortality in Nigeria's largest metropolis. And our goal of our program is to increase early detection of breast cancer among women through community awareness and accessible screening and treatment. Hannah, next slide. Afreen Sheikh is our program director. Unfortunately, due to some medical reason, she is not able to join. I, as a clinical director of this project, I developed medical frameworks, referral pathways, and I ensured the project initiatives are evidence-based and clinically safe. Now I'll let my other members to introduce themselves. Ernest, unmute yourself and introduce.
Okay, hi everyone. My name is Ernest Ike, and I'm a fellow of Public Health 360. In this project, I serve as the Director of Monitoring and Evaluation. Thank you.
Hello, everyone. My name is Hannah Zaina. In this project, I will be playing the role of the Director of Outreach and Communication, which focuses on strategic community partnerships and manages local media relations to drive widespread campaign engagement.
Next slide. Let's take an overview of this project. It is basically a 24-month project, and the location is Lagos, Nigeria, which is the most populous region and a hub with one of the most highest breast cancer burden. This program will adopt a multi-approach to reduce mortality, improve outcomes through early detection, and timely intervention. There's a beautiful saying that there can be a life after breast cancer, but the prerequisite is early detection. Next slide. Let us look over the problem statement. When we see globally, the breast cancer is the most diagnosed cancer worldwide, affecting 2.3 million women annually. In developing countries, there are different strategies to combat this early detection, like early detection, early treatment, and early referral. But when we look at the developing countries like sub-Saharan African and Asian countries, they suffer from highest breast cancer mortality rate globally. And when we look at the percentage, it's about 60 to 70% of the cases are diagnosed late like when we see late diagnosis as stage 3 and 4, in which the cancer has already done the metastasis to other part of the body, which is incurable. When we look specifically at Nigeria, breast cancer is the most common female malignancy. Globocan 2022 recorded over 32,000 new cases and 16,000 deaths annually, which is a huge burden on the economy. Now, looking at Lagos State, it records the highest number of absolute breast cancer cases in Nigeria, representing about 53.2% of all cancers which are being treated. Next slide. Our goal is to reduce breast cancer mortality among the women in Lagos State, Nigeria by improving awareness, increasing early detection, expanding access to treatment, and strengthening healthcare capacity within 24 months. Our objective is to increase the public awareness about breast cancer prevention and early detection, train healthcare professionals in early diagnostic and health treatment techniques, strengthen referral system, and provide psychosocial support to the affectees, patients, and their families. Next slide. Our implementation plan is awareness, in which in this project, we'll reach about 10,000 women aged between 20 to 60 in 2 selected Lagos LGA with culturally tailored campaigns over for 6 months, and we'll measure the knowledge gained through pre and post surveys during community and market outreach. When we look at the screening and early detection, this project will screen 2,500 women using MeCure healthcare mobile units and local healthcare center outreach between month 7 and 14. And we'll track a total number of physical screening, abnormal masses detected, and advanced scans which have been administered. For treatment access, the project will establish a direct fast-track referral pathways to Lakeshore Cancer Center for all patients presenting with anomalies beginning by 7 months and continue through 24 months. And we'll evaluate the success through speed of clinic handoff and under 14 days, and patient navigation completion rates. For capacity building, we'll train 50 local primary healthcare workers with the clinical breast exam techniques and early symptom recognition with all training completed by month 6. And we will use certification records and practical competency exams or assessments to measure the success. And lastly, for sustainability, this project will compile and submit a comprehensive localized breast health data reports to Lagos Ministry of Health by 24 months. And we'll evaluate through the success through formal policy acknowledgement, institutional uptakes, and institutional uptakes of the data pool, and continued use of trained healthcare workers in the local clinics. Next slide. Now, the expected outcomes of this whole intervention will deliver targeted breast health education across 2 Lagos high burden LGAs, which is Alimosho and Mushin, and will train 50 primary healthcare workers in early detection and clinical skills. We will conduct 2,500 free physical breast exam and deploy a mobile diagnostic van to provide 300 free advanced mammograms or ultrasound, which is required to high-risk women. We'll establish a community-led peer support group and guarantee every patient with the detected anomalies is safely transferred to Lakeshore Cancer Center within the 14 days. And lastly, we'll compile and submit a comprehensive diagnostic and prevalence data reports to Lagos State Ministry of Health by 24 months and strengthen the future health state policies. Over to Hana.
Hello, everyone. My name is Hana Zaina. I'll be joining from Dubai, UAE. So we will be talking about the target population, and we have segregated into 2 groups. Our primary group, which is our screening focus, is women aged 30 to 65 in Alimosho and Mushin who lack healthcare access, and these women are at high risk due to late-stage detection, low income, and lack of access to healthcare. In the secondary group, the support focus, we will focus 100% of our secondary efforts on the people who help us scale. These will be the 50 local healthcare workers who do the exams and the community leaders who mobilize the women. This ensures every resource spent directly yields a screening or a successful referral. Next is a strategic partners, and these partners will complement our team's expertise by expanding outreach into diverse communities, providing specialized knowledge and resources, and strengthening our credibility and trust through established networks. So this will include the Lagos State Ministry of Health. And we chose the Ministry of Health because we cannot enter Lagos communities like Alimosho, Ikeja, or Mushin without top-down clearance. A formal letter from the Ministry of Health commands immediate respect from local government area chairman, and this would ensure that we have free access to public infrastructure like the health centers or town halls for our screening events. Next would be our Christian Association of Nigeria Lagos State chapter, and this is a faith-based organization which would offer community mobilization, volunteer support, and access to congregational networks to promote our awareness on breast cancer and participation from the local community. The next one is the Lakeshore Cancer Center. We selected Lakeshore strictly as our referral backbone by routing high-risk patients that are diagnosed through screening to them to ensure that the woman continuously receives excellent care. The next strategic partnership we have is the MeCure Healthcare. And this was chosen because they function as a vendor. They have the mobile vans and mammogram machines that we need, and they operate as a business. So by paying or negotiating with them, we can improve the access of our breast cancer screening to the women in Lagos. Now we have designed a direct theory of change where every resource we put in leads straight to a specific outcome. So the first one is we have divided it into inputs, activities, outputs, and outcomes. The first one we have is our strategic funding. So we take our funding to launch market campaigns, which allow us to reach 10,000 women, ultimately leading to increased knowledge and broken stigmas. The second one is training modules. We invest in training materials to host workshops for primary healthcare staff, which creates 50 certified local healthcare workers, leaving behind a permanent medical safety net in those communities. Then we have mobile screeners. So we leverage MeCure's mobile diagnostic vans to run intensive local screening camps, and hitting our target of 2,500 exams and 300 scans, which directly catches potential cancer cases early before they spread. And finally, we use our partnership with Lakeshore and our data team to navigate patients and clean our data by producing 2 support groups and 1 final report. And this ensures a 100% safe referral pipeline and gives the Ministry of Health concrete policy data. So in our timeline and duration, our phase 1 is about building the foundation. So in the first 6 months, we focus completely on getting the community ready. We get letters from the Ministry of Health to get local government chairman on board, educate 10,000 women, and train 50 clinic workers. No screening happens yet. We are building trust and capacity. Then in phase 2 is our operational engine. From month 7 to 14, we move into the field with MeCure's mobile vans. We deploy to our 2 LGA communities, which is Mushin and our 2 LGA communities, and this will lead us to hit a target of 2,500 clinical exams and 300 advanced scans. And the phase 3 will handle the critical health results. So As we wind down screening, we focus entirely on the women who have shown signs of anomalies. We don't abandon them. We set up 2 support groups to help them emotionally, and we use our fast track pipeline to safely hand them over to Lakeshore Cancer Center for treatment. Our phase 4 would ensure sustainability and closure. In the final 4 months, we step back from the field, we analyze our data, package it into a comprehensive report, and hand it over to the State Ministry of Health. And this proves we have successfully executed our goals, stayed on the schedule, and left a lasting impact on state policy. I'll hand it over to Ernest.
Many thanks, Hannah. I'll be taking us through our evaluation plan. This evaluation plan was well structured to enable us to monitor and evaluate the program from starting to the end. And our method of evaluation includes pre and post intervention assessment to measure changes in awareness creation, screening uptake, and treatment adherence. We're also going to be tracking the patient's outcome to evaluate sustained impact. Community feedback will be looked through focus group discussion and stakeholders meeting. Our tools and technique will include surveys, questionnaires to assess knowledge, attitude, and practices related to breast cancer. We are also going to be leveraging on clinical data review to enable us have records for screening and diagnostic results. We're also going to be monitoring our dashboard. We're going to create a dashboard to visualize our program performance and indicators. Our qualitative interviews with patients will also help us to track our providers and community leaders. Our method of data collection will include qualitative data, which is also had to do with the number of women screened, dictation rates, and of early stage cancer, and also treatment interventions. We're also going to be using qualitative data to enable us track patient experience and satisfaction, barriers to screening and treatment. We're also going to have a method of collection through the hospital clinic record, mobile health apps, and SMS reporting. Community outreach logbook is also going to help us to get more details. Again, the outcome of our evaluation will include primary and secondary. For primary, we're going to look at to the increase in early dictation rates to improve treatment adherence, while for the secondary is to enhance awareness creation and reduce stigmatization. We're also going to be evaluating the productivity of efforts of our staff, like for the number of screening conducted per healthcare worker, the efficiency of the outreach campaign, and also our resources will be evaluated, the budget spent versus the planned equipment used for the project. Efforts too will be tracked so as to enable us come out well in our project. The time invested in training our outreach participants, patients follow-up, and the rest of it. The capacity building training will also be monitored and evaluated. We're going to be looking at that to make sure that all the participants are well trained, and also the audience are also aware of the measures they are going to take should the need arise. Next slide, please. So we have also carefully mapped out our key performance indicator, and we categorized it into 3. The outcome evaluation, which will include the screening uptake. That's the percentage of increase in women screened for breast cancer compared to the baseline. We're also going to look at the early dictation, that's the percentage of case diagnosed at stage 1 or 2 of the breast cancer. The treatment adherence too will also be part of our indicator, where we're going to also check the percentage of patients completing prescribed treatment. productivity and effort evaluation will also have its own KPI, where the staff efficiency will also be used to measure the outcome that they have put into the project. For example, the average number of screening conducted per healthcare worker per month. Like I earlier said, our capacity building also has its own KPI, where we're going to be tracking the training impact and also the infrastructural growth. Next slide, please. In order for us to meet up with time and not to exhaust our budgets, we are going to have a dissemination plan. And that dissemination plan cut across the information and communication. We'll be looking at the community outreach campaigns and organize awareness events, and also the educational material to be distributed, like the posters, the infographics, and strategic or key areas in the clinic, town halls, and other places where people can easily see those informations. Our digital platform is not exempted. We are going to maintain a dedicated website that will be used to publish or to showcase all the events that have been going on within the project. And we're also going to make efforts to align our outcome with the policymakers to enable them have easy decision making. When we have good outcome, it will really help to improve this in making decisions within that space. We're also going to be looking at, back to that slide, please, I'm not done. We're also going to be looking at the social media space, because we know that when we publicize all the programs, the progress, and where we are, where we have gotten to, it will really help to create more awareness. We are going to be leveraging on our Facebook, Instagram, X, LinkedIn, and infographics and videos to show people what we are doing and to create more awareness on that. Our hashtag strategy will be top-notch. We'll be creating a hashtag, a unique hashtag that will help to unify us online. And interactive content will also be used, like the use of polls, question and answers, live streaming, and the rest of it. Next slide, please. As stated earlier, our dissemination of information is going to be time-bound, so as not to exceed the time that we have allotted to the project. So we're going to be doing it in phases. We're going to have the short time, which will include the program launch, and it's going to take us like 1 to 3 months, where we're going to be having our public awareness campaign, the launch of social media pages, distribution of flyers, posters, and brochures to clinics, community centers, and the rest of it. We're also going to be engaging local radio and TV stations for introductory coverage. Our stakeholders will not be left behind. We're going to also engage them during that first quarter, or during that first time that we're going to start the program, that first quarter. And the second bit is the midterm, which will include the implementation, and it's going to last for like 8 months. We're going to be doing our progress updates, going to be getting in touch with our sponsors, our donors on a quarterly basis to share our progress with them. We're also going to be publishing our infographics and short videos to make people see what we're doing and also to know where we are. And we're going to be hosting community forums to inform them too, to make them know the stage where we have gotten to. Documentation will also be key. We are going to ensure that we have success stories so that we'll reach out to our donors on it. While the long term is going to be the completion and beyond, which will take like 12 months. Which will include the final result dissemination, publishing our comprehensive program report, and also maintaining online posters and guides to TikToks and the rest of it. So those are the things we are going to be launching through in our long time, which is also the completion of our project. Next slide, please. For us, we are mindful of the budget, and that's where we really took our time to plan our budget. And in preparing our budget, we also understand that it won't be more than $200,000. So we have a plan that is approximately $200,000, and it's going to last, the program is going to last for 24 months. Next slide. So some of the items that we have planned for, it includes all the activities that we're going to carry out during the project, ranging from personnel costs, training and capacity, outreach activities, medical supplies, monitoring and evaluation, information and communication, media publicity, and the rest of it. And I think the highest in that budget is that of the medical supply, which has about 28% of the total cost. And of course, we're also mindful of our miscellaneous, which we have carved out like 10% of it to be able to have our contingencies should the need arise. So we have approximately $200,000 as our budget estimated costs. Next slide. For proper enhancement and efficiency of our program, we have also taken our time to plan our staffing. We all know that without the manpower, the project will not get to where it's supposed to get to. So we have carefully planned our staffing, ranging from our project director down to staff that will be hired, both from within the community, and we'll also be working with our provider staff. We have also strategically designed a volunteer pool where it will also help in reducing costs of our personnel management. So these are some of the plans that we have, and we are very, very hopeful that by the time we submit this and we have been sponsored, we are going to have a very smooth execution of the project. Back to you, Hannah, for closing and conclusion. Thank you.
So as we conclude, this is a 4-phase execution timeline, with distinct monitoring and evaluation metrics and clear data dissemination pathways. This project will not only save lives across Lagos, but will also establish an empirical scalable model for preventive oncology capable of replication throughout Nigeria. We welcome the opportunity to partner with your organization to turn this vital public health vision into a sustainable reality. And any questions?
Excellent, excellent, excellent. This is great. This is good. This is very good. So the Pink Shield project to be implemented in Lagos, the commercial city of Nigeria, right? Nigeria is Africa's most populated country, 200 million people ish. So, and they have chosen Lagos, which is the most developed state in the entire Nigeria. So this project, they are proposing 10,000 women to be educated. They are proposing 50 healthcare workers to be trained. They are saying that they are going to conduct 2,500 physical examinations, and then 300 advanced scans. And then they are going to create 2 support groups. There are a lot of questions, and the group has been really, really very, very active. Okay, so briefly, I think the question about evaluation was done before the evaluation plan came in. So let's talk briefly how, in a nutshell, how do you plan to evaluate the success of this program?
Well, for us, we know that in every project, you must have a monitoring and evaluation plan. And for us, we intend to progress with our evaluation at the start or the beginning of the project till the end. And while we're doing that, we'll keep informing or sending our reports. I rightly said it while I was making my presentation, on a quarterly basis. With that, we're going to be able to track our activities, and by so doing, we'll get to where we want to get to.
And that is the process evaluation that was also asked. But there was a comment that there was no budget allocation for evaluation.
There is, it's there. It's there. Can you go back to the slide, Hannah?
Oh, there is 11%. Okay, 11%.
Yeah.
Very good. Okay, and the next question is about the theory of change. Dr. Mensah, do you want to talk about that?
Yes, if you'd allow me. I mean, it's impressive project, very, very nice, very detailed and everything. I teach program implementation and evaluation, so I'm pretty passionate about it. I teach logic models as well. So what you showed us was the logic model. One thing I think you guys might want to do, if you want to take us back to that slide, you know, when you create the logic model, when it comes to activities, your activities should be action-oriented. It's what are you going to do? So maybe conduct multilingual campaigns, build capacity or organize capacity building workshops, engage in field diagnostics, conduct patient navigation. It's got to be action-oriented because it tells you what you're supposed to do. What are the actions? What are the events that you want to engage in to be able to arrive at your objective, achieve your objectives or your outcomes? Now with outputs, we don't ask that you put a number there because the way you have it right now is looking like an indicator that has standards, right? So you just want to say women educated or number of women educated, and then you set your standards. If you say, then when you come to the, when it comes to doing your M&E plan, that is where you put in the numbers, like your indicator. So you've had your data collection plan. What is your evaluation question? All evaluations begin with a question. What are you trying to answer? What are your indicators? And then how will data be collected from what source and how often? So just to keep that in mind, because it pretty much, when I saw it, I was like, okay, this is a good attempt, but there's something small missing. Yeah. But again, I'm very impressed.
Thank you.
Thank
And
you.
that is the feedback for all the groups, right? That's the feedback for all the groups. Theory of change, logic model. I think that's an opportunity there. All right. The other question is, what are the limitations of this intervention? And that's a good point. I didn't see anything anywhere where you said, we feel that these are the challenges or these are the issues or the limitations. Can you talk briefly about some limitations?
Okay. Can I? Okay. So the limitations that we're envisaging for this program are, like we know, Lagos is more like a metropolitan state. We also know that we have different languages there. So we're going to have language barrier, and we're also going to have cultural differences. So we're going to structure out those barriers to see if we can have some team of people that will help in bridging that gap. That's what we're looking at. Thank you.
All right. There's another question about policy. What are some policy, existing policies regarding screening or treatment for breast cancer?
I'll take that question. So there is a Lagos State Health Scheme, which does cover treatment and screening for breast cancer. But the problem, the gap that we researched was that the community wasn't, they had knowledge on breast cancer, but they weren't exposed to those schemes. So they don't have knowledge on the schemes. So they know about breast cancer, but the outreach or the dissemination of that policy hasn't reached those local communities. So to bridge that out, we would encourage, we would also include in our training modules and our campaigns to make sure that the local community knows about such government schemes that are present, and then hopefully connect them to those.
And I think the key point here is that when you are designing a program, ensure that that program is aligned with government policies. That really makes your success easy, because government will say this program is coming to solve a problem that we have identified. And that could be a core linchpin for evidence to say, the Lagos state government has issued a policy for early detection, early treatment, and early cure for breast cancer, and this project is aligning with it. Then when you are asking for Ministry of Health later, people are going to say, yeah, they are coming to support what we want, because every government is looking for somebody to solve problems for them, right? So that's really good question. So there was another question here about money. They said that the the fund that you are requesting is it too short? Is too much for the project? I think that's what I heard. Or is it too small for the project? Please feel free to, Mohammed, please feel free to unmute so that I don't misrepresent what you say. Say the budget requested is too much short to achieve the project objectives. Okay, that you have requested less than what you have proposed to do. What is your comment on that?
We thought as much too. We discussed that, and but we had a gauge as regarding to where the amount that we are going to limit our project to, because even when we made inquiries as in regarding to equipment, we also found out that it's not even going to be enough to get those equipments, but we had to follow the instructions.
Good question. The funder has only $200,000, right? That's the answer. And we know that in program development, you got to align with the funder. If you make any request greater than 200,000, they would consider you non-responsive and throw your proposal out. They don't mess around. All right. Okay. All right. What are the potential funders for this project? You can say briefly about that. Where do you think you might get money to implement this project?
Well, for us, I know that my colleagues will also make inputs. We're looking at fund. We have currently indigenous funders that we're going to be looking at. I know that Dangote has a foundation, and currently, because of the eminence or the prevalence of this case, he will be very, very interested in pushing out money for that. And international donors too could also be approached. I was discussing with someone, and he said that particularly the Asian countries are very much interested in it, that we can reach out to them too. I don't know if any of my colleagues will make more input on that.
Very good. We gotta move on. Okay. So the other question was, how do you plan to implement this program in the near future? I think that was what you said, right? The goal here will be upon graduation, we're going to have a framework for bringing the group on, and then we're going to look for potential funders and then see how the whole project will be crafted. You remember, the fellows are distributed around the world. Ernest is in Nigeria, Hannah is in Dubai, Bushra is in Pakistan. So we need to find a mechanism through which we can create a group, and then we can always draw from other groups. All right. Another limitation here we have is that digital divide to access to online information could be another one, right? In Lagos, especially for the areas that you are participating. All right. Lagos is multicultural. I'm excited about this project. Let me tell you, Ernest is the only person from Nigeria, and Ernest does not even live in Lagos. The other people, Hannah lives in Dubai and Bushra lives in Pakistan, but you can see that intentionally they have become experts in global health programming in a different country. That is the intention of this program. And you can see the way they are talking about Limosho, Mushin, Lagos, local government really told me that they have become experts in global health issue in Nigeria. Very perfect. Let us show them some love again. Please use your react button, show them some love. Thank you so much. Excellent project. Very good. Very good. All right, now we are moving to group number 2. Group number 2. Brown, give them to share. And group number 2 is also going to have 20 minutes, and the clock starts immediately they start. And then I'm going to tell them 2 minutes to end, and then we're going to take questions. Please keep your questions coming so that we can learn as much as we can. And I see there are also people on YouTube that are watching the program as we present.
Okay, can I start?
Yes, go ahead. Yes.
All right. Good morning and good afternoon, everyone, since everybody's joining from all over the world. My name is Temesgen Tariku Chifao. I am a Public Health 360 Fellow. I'm joining this session from Washington, Seattle, United States. And then I would like to call up my team members to unmute and introduce themselves. So our topic is Mind Forward Akira MIFA, a school-based youth mental health, illness awareness, and early intervention program in Nima, Greater Accra region in Ghana. Thank you so much.
Good evening, everyone. My name is Sarah Catesby. I am from the UK. I'm the project director. Thank you.
You can unmute yourself. You are muted.
Comfort, unmute.
Yep.
Hi, everyone. My name is Comfort. I'm joining from Massachusetts. And for this program, I'm the Director of Technology and Platform Development.
Okay, next slide, please. So our learning objectives are, by the end of this presentation, you will be able to understand the scope of youth mental health challenge in Nima, Ghana, identify MIFA's 5 SMART E objectives and program goals. The SMART E is an abbreviation. It stands for specific, measurable, attainable or achievable, relevant, time-bound, and equitable. And also we will describe the core activities, logic model, and methodology. And also we'll summarize the evaluation, staffing, and budget structure, recognize the 24 months outcomes and impacts. So our course outline is, the first part is community need and background, the program goals and SMART E objectives, core activities and logic model, evaluation, staffing, and budget, and then also 24 months outcomes and impact targets. So here we have the problem statements. Youth mental health disorders are becoming a major public health challenge globally and in Ghana. The World Health Organization estimates that 1 of 7 adolescents aged 10 to 19 years experience a mental health conditions with depression, anxiety, and behavioral disorders among the leading cause of illness and disability among young people. Suicide is also one of the leading cause of deaths among people aged 15 to 19 years, according to WHO 2021. So in Ghana, mental health service remain underfunded and inaccessible, particularly in poor urban communities. According to WHO 2022, Ghana Health Service 2021, young people living in low-income areas such as Nima in Accra face unemployment, poverty, overcrowding, substance abuse, violence, academic stress, and social stigma surrounding mental illness. These factors contribute to depression, anxiety, suicidal ideation, and poor help-seeking behavior among youth. So globally, adolescent age 10 to 19 live with mental health disorder is 1 in 7. Suicide is the third leading cause of death among youths 15 to 29 years old, according to WHO 2025. 13% of Ghanaians live with a mental disorder, according to Ghana Mental Health Authorities 2022, and less than 2% of those affected receive treatment in Ghana, according to Ghana Mental Health Authorities in 2002. Next slide, please. So why we focus the NEMA community in Accra, Ghana, because NEMA is selected as the intervention site based on verifiable needs assessment data from the Iowasso East Municipal Health Directorate in 2023, which identifies high youth unemployment, 28%, substance misuse, 32%, exposure to violence, 41%, and school absenteeism linked to emotional distress, 18%. According to the Ghana Statistical Service, GSSS 2021, and the Ministry of Education Management Information System, EMIS. Basic schools in densely populated urban communities such as NEMA typically enroll several thousand students collectively due to high population density and limited school infrastructure. Next slide, please. So in MIFA community reach, there is 10 schools that we selected for this project in Accra region, with many basic schools enrolling 400 to 900 students each, and school clusters serving over 2,000 students collectively. MIFA targeted 10 schools across Islamic, Christian, public, and private schools serving over 2,000 students. So Islamic Training Institute, ITI, NEMA, Answaruddin Islamic School, NEMA, Saint Kizito Roman Catholic School, Mount Zion Methodist Basic School, NEMA Cluster of Schools, NEMA 24 School, the Youngsters International School, Henrietta Preparatory School, Lincoln Montessori School, and Anani International Schools are the 10 selected schools for this project. So the 10 schools were selected through a targeted data-informed process designed to ensure broad, equitable reach across the diverse youth population of NEMA. Selection began with mapping all school and junior high schools in the community, and identifying schools that serve large numbers of adolescents from low-income households where mental health vulnerabilities are most pronounced. Sarah will continue. Thanks so much.
Yeah, thank you so much, Mescan. Yes, our next question will be like, why do we have the program? What is our program goal? And in this case, we have 2 goals, which is build lifetime emotion skills and also close the gaps in access to care. We'll be building the lifelong skills through promoting positive mental health among youth who are aged between 15 and 24. And I would also want to make mention that these are the groups whereby there is a lot of suicide. They normally happen around this stage of 18 and 24. And sometimes we think this is developed from the youth, the adolescent stage, where there is a lot of mental issues that are not tackled, that are not helped at early stage, and then it develops when these young men become like at the stage of 15 and 24. That is when a lot of suicide happens. And also on the Cross the Gap, we want to make sure that the friendly mental health support is accessible in underserving NEMA, where stigma and resources gaps restrict early detection and care. Next slide, please. We will be using our SMART E objectives, 5 of those within the 24 months of our measurable target. And the first one will be on mental health literacy. We'll be working between the 24 months that we'll be working on this project, we'll be aiming to work with 2,400 students, and they'll be completing 4 literacy modules, and we hope to improve 50% of their knowledge score by the 24 months. There will also be emotional awareness, which we hope by the 10th month, 2,400 students participating, like 50% of them would have improved their ability to identify and label their emotions. We'll also have the health coping skills by the 24th month. We hope that 80% of the students will demonstrate at least 3 healthy coping strategies. Next slide, please. Yes, we have the 4th, is our SMART E objective, which is early identification and screening. And this will be happening on the school base. We'll be having the screening done in the school. And before we get to the other side, we'll be having the healthcare workers and trained people who will be able to use these tools, and conducting the trained teachers and community health nurses who will be able to conduct the screening. And also with our MIFA peer support club, we are planning to have 10 school-based peer clubs, which will be around 20 to 30 members each, and it will also be facilitated by the peer leaders. Next slide, please. How would we deliver? What are our core values? Core activities. What is it that we are planning to do? Our first one will be on mental health literacy, which will be like a 4-structured module on the stress, emotion, stigma, and health seeking. And going on the stigma and emotion, we want to understand that Ghana is one country where issues with mental health is not very much spoken. And this is based more on the cultural structure. People think if you're having mental problems, it's associated with demons. So it's not a very spoken program. Subject. Parents are ashamed when anything like this happens, because there is a lot of judgment. There is a lot of stigma surrounding the mental health. So it's really difficult for people to come out for the help that they need, and to also understand that mental health are issues that are suffered by everyone, not just people in Ghana and associated with culture or tradition or belief or demonic powers. Is beyond that. But this is the awareness that we also want to be bringing on our second core activity, which is emotional awareness, guided journalism, mindfulness, and grounding exercises. These are some of the things that we'll be using with the young people. We'll be working with the young people to make sure that they understand, that they learn that how to cope with their mental issues. And that brings us to the 3rd, which is coping skills and training. The student practice deep breathing. They'll also have problem solving and positive self-talk. There will be also early screening and virus, validated screening tools at risk youth connected to care. And in this, I think, will be coming also to the from the next slide. We have like 2,400 students who will be working with, and among those, we believe not everyone would want to come out for the screening. So we will probably have like 2,400, 2,000 coming up. And out of those, we will probably have 100 who will have high risk. And we can also refer them to care and support. So the 5th one being MIFA Peer Support Club, there will be a weekly student red groups where we'll be discussing and helping these young people. Next slide, please. Our theories of change and our logical model, we have 5 inputs that we'll be working on. I mean, we have 5 logic models that we'll be using, and that is the input, the activity, the outputs, the short terms, and our long-term goals. What is it that we are looking to achieve? What is it that we need to do? First of all, we want to have our trained staffs on our curriculum. We want to work in partnership, and we also want to have screening tools available. For the activities, we have like 5 core activities across the 10 schools. And also on the output, we want the student to participate. We'll have the peer, the support clubs, where we want people to come and be participant and speak the issues. And also on the we'll be having the screening happening on the students at that same time. With our short-term outcome, we hope to increase literacy, reduce stigma, and also better coping strategies. And for our long-term impact, improve youth mental health, as well as sustain school system. Our next slide, please. So the direct impact here will be serving young people aged 15 to 24. They are in Accra, Ghana, in a place called Nima, which is a small, diverse, resilient community, but poor. They are faced with poverty. They are also faced with unemployment, overcrowding, and most of the children who live in the young people who live in this residential, in this Nima place, most of them are young adults aged below 25 years. So Ghana, we also understand from our research that there is only 1 psychiatric per 1 million people who are suffering, and that is huge. That is huge, because that means so many people are not, in as much as they want to help, there is nobody there to help them. There is no professional enough to help the people that need help. So there is a lot of work that need doing. And also there is indirect reach. We'll be using the teachers, the caregivers, the community workers, and the parents, of course. So next slide, please. And this will be my last slide. We'll be working with multiple partners and sector approaches, which the first one will be planning to work with the schools. We have selected 10 schools that will be working with the implementations hub for all the programs. We'll also be working with Ghana mental health authorities, technical guidance and national policies, Islamic Council, because again, there is a divide of religion here. We have Christian and we have the Muslim. So we have to make sure all the teams are represented and all the councils are represented. So we'll be working with that community in mobilizing and stigma reduction in Nima. We'll also be working with the Christian Council, which will be parent sensitizing and mental health dissemination. We have Ghana Health Services, who will be helping us with the screening, clinical oversight, and referral pathways. And last but not the least, we'll be using Ghana University School of Public Health. We'll be monitoring and evaluating and research support. I'll pass on to Comfort from here.
Thank you, Sarah. So I will be coming in from here, and our timeline, it's a 24-month program, but we intend to have it for every year. So the first year, we hope that in January there will be we'll launch the program and then have the mobilization activities rolling on. And then from January to February, we hope to start training, having training workshop for the staff that will be selected for the project. And then from January to March, to June, by then we believe that the schools have been contacted, everything is in place. So we start our first activity, which is literacy and emotional awareness. Then from March to July, we begin the clinical, the mobile clinic for the screening and all the stuff. And since it's a school-based project, we believe that in August, there will be long vacation for the students. So during that time, we will not have the field activity, but we may be like the committee or the group, the team, maybe having some logistic meetings, but not longer going into the field to work with the students. And so then in that March to July, and then September to November, there will be that peer support groups. There we hope that by that time we start establishing the MIFA club support peer support club in the different schools as time will go on. So in February to July and then September to December, we hope that we begin the material distribution that will be used during the project. And then January to December, automatically, we know that the beginning of the project, automatically monitoring and evaluation is ongoing. And because at the end of every session or every activity, there will be that need to sit back and evaluate the activity and see what went wrong, what went well, and where needs improvement. So that would be like a whole year process thing. And then November, December, we hope that by then we have a concrete written report that will be given to the people in charge, in authority that are concerned. And so we hope that at the end of the first year, the second year is going to mirror what has happened in the first year. And if there were other places of improvement, we need to scale up. The expected outcome by month 24 at the end of the program, we hope that at least 50% upgoing student we registered that they have improved, and there is great improvement in the mental health knowledge. And this will be measured by the pre and post test literacy assessment that will be administered to them. And then we hope that there will be reduced stigma and negative attitude. Joseph Sarah was talking about stigma. We hope that at the end of these 24 months, there will be great improvement in that. And this will be measured by the end of program survey. And then 70% of the students of the participants will also believe that they will have emotional awareness. And so students will be able to identify and label emotions accurately and no longer attributed to maybe evil forces or other stuff. Expected outcome continue. So we also hope that 80% of the students will develop healthy coping skills. At least some students will be able to use 3 coping skills independently without the support of anyone. And then we hope that the MIFA club at the end of the project, the MIFA club will be established and it will be rolling. And at least if each school has about 20 students or more, then we are hoping that we have about 250 plus student active members who will be reporting increased belonging and will be able to help their fellow peers, fellow students in the school to manage that, owing to the fact that Ghana has a little professional psychiatric personnel to help people who are suffering with mental illness. And then we also hope that we are targeting 2,400 students, but we believe that not all of them may be willing to subject themselves to screening. So we hope that 2,000 students will be screened. And out of these 2,000, we may have 100 high-risk students who will need to be referred to special care, to special professionals. Evaluation framework. We intend to use a mixed method kind of framework. So how we are going to measure an outcome evaluation, we are applying a pre and post test survey where it will measure the stigma scale and then the coping efficiency tools. And then under productivity evaluation, we are going to keep activity log. There will be session checklist and then monthly dashboards. We also, the process evaluation, we intend to use fidelity checklist to ensure activities follow planned protocol. And then impact evaluation, we're gonna have interview with the students because some things may need a follow-up and the survey may not be able to give us a detailed explanation of some of the things that may be going on within the kids. So through interview, we hope that we'll be able to get, especially the impact of the program on the students. So operational team project staffing plan. So key personnel, we have the position program director who will be responsible for strategic program leadership. And then we have the director of outreach, who will be community outreach and stakeholder engagement. And then the director of technology and platform development will be responsible for technology, digital tools, and platform development. And then we have additional staff that we hope to also hire. And so one of them is we have the technical lead who will be responsible to provide strategic direction, coordinates with GHS, GMHA, and Ghana school leadership. And then we also have a program director who will be responsible to see to the day-to-day coordination of our program with scheduled school sessions and screenings. And then we have mental health specialist who leads mental health and content, and train teachers and nurses in early identification, oversees screening and referrals, provides clinical supervision, and then monitoring and evaluation officer. We hope that this person will be able to lead data collection and data analysis, since we will need professionals in the field for that, and then conduct a baseline, middle line, and end of line assessment, prepare evaluation reports, and ensure that data quality and ethics are being followed correctly. And then we need a community engagement officer. This person will lead parent and community engagement. This person will also work with Islamic and Christian councils, support stigma reduction campaigns that we will have at the end of the day. Our budget overview, we are budgeting $200,000, and we hope that $75,000 will be used for personnel, which we are going to have about 8 facilitators, licensed clinical specialists. And then we hope that $105,000 will be used for non-personnel, comprising of all the communications that we do, the supplies of equipment and professional development that will be after, all the campaigns that we'll be doing, and the outreach to like synthesize, like at the end of the project, we hope that students will be able to like share to the community what we have done. So all those expenses will go in there, and then $20,000 for indirect and admin cost of 10%. So in conclusion, we hope that MIFA builds a sustainable, culturally responsive mental health support system that empowers students, equips educators, and engages families and communities leaders in promoting well-being and reducing stigma. FIFA addresses youth mental health, literacy, emotional awareness, coping skills development, early identification, and keep support strengthening and peer support strengthening. MIFA embeds support within schools where youth spend most of their time and where early signs of distress can be recognized. MIFA combines community-based outreach, policy engagement, transparent reporting, and dynamic social media communication. MIFA also contributes to the broader evidence base for school-based mental health intervention in Ghana. Thank you.
Very good, very good. Let's show group 2 some love. Thank you so much. This is great. This is incredible. MIFA proposes to provide a mental health intervention for youths in Ghana, Nima, Ghana. They propose to work in 10 schools. These schools are both Christian, Muslim, private, public schools. And then they are going to educate about 2,000 students. And then I saw another 2,400 students. So there are a lot of questions for you. So let's get to the questions so that we can go to group 3. Number 1, somebody had asked this group, what is the difference between, I want you guys to pay attention. I don't want distraction with the slides. Just go to the beginning of the slides. No distraction. I want the group to pay attention because these are your questions. I don't want you spending time on slides when we are posing questions.
Okay.
All right. Okay. So somebody asked, what is the difference between stress and anxiety?
Well, stress is a immediate, or it's a immediate reaction, a quick reaction for the known reason that could be upcoming or already past. But anxiety is it's a persistent, and then it comes from inside.
Okay. Stress is temporary, time-bound, and anxiety is clinical, right?
Yes.
Excess stress, once stress passes a level, then stress becomes anxiety, which can be clinically indicated. Okay, very good. Next question. You have a good question here. They said, the question said, when do you plan to collect the data, baseline data that you will be used to make claim about NEMA and the youths?
According to our data collection worksheet, before we begin, when we get the participants that will partake in the program, we are going to administer a pre-test survey on the participants, and then we collect the survey before we begin the project. We'll begin our activities with them. So after the end of the program, we now administer another survey, which is a post survey, and then use this tool to evaluate the project. So in the post survey, we also comprise of interview, because at the end we want to evaluate the impact of the program as a whole. So we do that at a time.
All right, Dr. Armstrong, go ahead.
Yeah, so when you talk about impact, you're talking about control and intervention groups. That's how you can that's how you can measure impact, right? So not through just interviews, right? So you've got to have a group that that participates in the intervention, and a control group that does not participate in the intervention. And that's where the pre and post surveys become very important, because prior to, you recruit people, everybody gets to take the pre-survey, then the intervention group that is randomly selected gets the dosage, then you bring them back, and then you administer the post-survey, and that's how you get to know what the impact is. Am I making sense?
Yeah, there is that aspect of data collection in a mixed method like that, but at the same time, you can also administer pre and post on the same group, because this group, before the intervention, they were there without the intervention. So you want to know what was their understanding of whatever you are bringing now before you did the intervention. So after the intervention, you want to check, is there any change in their thinking, in their belief, in their understanding of what before the intervention? So it could also be within the same group, and then in another instance outside different groups. If you want to make a comparison of using t-test in order to measure and find the difference between the distance, you can have two different groups. That if we don't want that, we can do still within a group.
Well, then what you're talking about is the quasi-experimental method, because that one, you don't really have a group that you're comparing them to.
Yeah.
But the gold standard is the experimental design, where you have the control and the intervention, and that way you're able to claim attribution or contribution. But I get what you're saying.
Okay.
All right. So I saw two numbers in this proposal, right? I saw a 2,000 students where you mentioned the 10 schools, and then I saw another one, 2,400 students. I'm confused.
Yeah.
What is the actual number that you are addressing?
Our actual number we are addressing is 2,400. So, but when it comes to the screening, don't forget that when you're doing a study or research of that magnitude, you give the participants the freedom to choose to participate in certain things or not. So we are hoping or thinking that if we have 2,400 students, probably out of the 2,400, only 2,000 may agree to be screened.
I see. It
Yeah.
wasn't clear, right? I think what you are saying is the overall recruitment and effective sample size. It needs to be clearly classified. That you are saying
No.
the outreach is going to enroll
let me-
2,400, and then you don't need to tell us how many people, because that's a hypothesis. You need to allow the program to run, and then in your report, you're going to say that you had estimated to have 2,400, but eventually X number. I think you put yourself in a disadvantage by saying you're going to recruit 2,400 and that you are going to have 2,000. I think that's, and I see nodding heads here, so I'm going to allow others to weigh in.
Sorry, before they come in, I just want to clarify something I'm feeling that we are not getting it. The 2,224 will still be part of the study. Yeah, but probably they are not willing to partake in this screening method. Yeah. So even if they don't allow themselves to be screened, it doesn't mean that they are out of the study. They will still be part of the study.
I think the question is,
No.
why do you have two numbers?
Right. No, I think what Dr. Azwini is saying, a comfort, is this: when you're going into research, you don't know who is going to participate and who's not going to participate. You don't start by saying, okay, 24 and 2,400 and therefore 400. You don't know. What if it's only 200? What if everybody comes? So what Dr. Azwini is saying is start with the 2,400 and then do the study. If you didn't reach all 24, then you tell them that when you started with the program, the idea was to screen 2,400. But based on X, Y, and Z, we only ended up with 1,800, which is fine. Nobody holds you. But if you say you're doing 2,400 and then you get to 15, I mean, if you set those parameters, it's like you've already made up your mind. You haven't even done the study yet. And why are you saying X, Y, and Z? That's what Dr. Azwini is not saying we don't know that they're going to be, but he's just saying don't make those statements ahead. Let the data collection process be the determinant of what you're reporting.
And again, it's going to affect the budgeting.
Okay.
All right, next question. Next question. You have a good question here. The question says, how are you going to ensure that the voices of the youth, the students for whom you are doing this program, are represented in the program leadership?
Good question.
Dr. Mensah wants to help.
What do you say?
Okay.
I mean, what I'm trying to say here is that if you're doing a program for the youth, right? Many a time we assume that we know what they need, but sometimes we get it wrong, right? You want your program to have relevance, right? So when you get the youth engaged, you get to know what their real needs and experiences are, right? You hear their voices, they help you plan, so it's good to think about them, but also have a place for them when you're planning and you're designing, so they can also say something.
Okay. Noted.
Yeah, usually in broader studies, we have community advisory board. We have research advisory board. One thing to consider here could be you have a youth advisory board, or you can have even a CAB where you have community members whose children are going to enroll in this study. You're going to have teachers who are going to, because they want to know what you are going to teach them. You don't come to our school system and grab children and teach them. We don't know what you are teaching them. So you want to have parents in that group to be able to advise you where you go to get things approved before you implement.
Okay.
All right, next question. And we're going to take this, is going to be the last question. Stigma. There is stigma around mental health. How are you going to address stigma against students who are going to potentially participate in your program? We have Sarah, we have Temesgen, we have Comfort. Come on.
Under our, what is it called? Data collection worksheet. It's a table that is under appendix. There we have some issues under cultural and other considerations. And one of the things we say is like students who come with deep-rooted stigma around mental health, and what are the possible things that we can do in order to help them participate freely in the in the um in the group, and we're like, we give them the room to like let them talk, so that we not presume that we know this is the stigma because we have read, we know these things, but let us give them the room to talk. And then when we talk together, we rub our minds on the solutions to them.
Right. Temesgen and Sarah, I want to hear from you guys. Stigma is imposed through perception by outsiders. So people who are already in the program are not stigmatized. It's people outside that are going to stigmatize them. And people outside who hear that they are participating in this program, they will say, oh, you got something wrong with you. That's why you're in this program. So there has to be a perceptual intervention intentionally implemented by you to address stigma. And when you address stigma, you can get an increased enrollment. What is that? Comfort, not you alone. You have two other group members.
Yeah. Yeah, I think I'll just add to what Comfort is saying about giving the youth the voice. Just reassuring them that it's okay to speak, that it's okay to talk about mental health, that this is just part of who we are. We are human beings. We've got anxieties, we've got depression, we've got issues. It's not just based on culture. And again, reading about Ghana is quite deep rooted on the spiritual aspect and the culture. So that will be a difficult one to try and get people to come out or even to accept that they have issues and it's okay to have those issues. But as Comfort is saying, I think the best thing probably will be, empowering them to speak out, empowering them to feel free to speak about how they feel, to speak and know that they are heard, that somebody is listening, somebody is understanding them without judgment, without prejudicing, without, they shouldn't feel embarrassed, shouldn't feel ashamed, and they shouldn't even worry about the outcome. They should just be themselves and learn and also speak out how they feel and how they understand about the mental health. And
all right. Okay. Very good. This is Mind Forward Accra, MIFA, right? A school-based youth mental health illness program, awareness and early intervention program in Nima, Accra, Ghana. Excellent, right? Sarah Kesby, Comfort, and Temesgen are not Ghanaians. Never been to Ghana before, right? And they have created a program to address an existing mental health issue in Ghana. The goal here, again, intentional to create experts, right? And one of the things we do is that we are so insulated to ourselves. The only way that true wisdom comes is when we become vulnerable and go to a different country and start to learn afresh. And that is what we have seen in this program. And all the questions we're asking is for you to consider when you are implementing a program elsewhere. These are the nuances, those are the blind spots. Dr. Mensah also added a comment about the logic model improvement, which is consistent to the previous one. But ladies and gentlemen, join me. Let's give them a warm round of applause. Excellent work, MIFA in Nima, Accra, Ghana. Hopefully we can go to Ghana and implement this program right there. Excellent.
We're planning all over
Yes.
that.
Yes, we are ready. We are ready. If you guys are ready, we are ready. We're going to go to Ghana. All right. Group number 3 is excellent. We are excited about that. Another 20 minutes. This is like a festival, right? It's almost like a conference. I'm learning free. I'm not paying. We have our colleagues on YouTube also joining us. So group number 3, are you guys ready? We are ready for group number 3. Where are they? Where are they? Where is Maria Chinyerem? Where are they? Where is Sarah Yeni? Where is Julie here? Are you guys hiding or what? I can't see you guys.
Yes, I'm here.
Come on, Julie.
Yeah.
Come on, Julie.
I'm here. Can Sarah unmute herself, please?
Good day, everyone. This is Group 3, and I and my team members will be presenting our intervention, which we titled Breaking the Sugar Cycle, Karachi, Pakistan. Now, imagine waking up one day and realizing that you have a disease that could have been prevented. Now, imagine this disease affecting over 34 million people in one country. That's the reality of people in Pakistan. And my team members saw this issue, and then we had a question on our minds, which was, how do we address this issue? And BSc Karachi was the answer. So the aim of this intervention is to decrease the incidence of type 2 diabetes mellitus in Karachi, Pakistan. Next slide, please. I am Dr. Ayeni Sarah. I'm a medical doctor from Abuja, Nigeria, and I'm the project director. I'll let the rest of my team members introduce themselves.
Hi, everyone. I am Maria Chinyerem Onyekane. In this project, I serve as Director for Monitoring and Evaluation.
Good evening, everyone. My name is Dr. Munawara Mohammed. In this project, I am the clinical director, and I'm joining from Nairobi, Kenya.
Hello, everyone. I'm Julie Herr, and I'm the Director of Outreach and Communication, and I'm located in the USA.
Good afternoon, everyone. I'm Dr. Unity Dokifa, an ophthalmologist. On this project, I am the Director of Strategic Partnership. Thank you.
One thing that really stands, please, can you go back to that slide? Thank you. So one thing that really stands out about our group is the fact that we are multidisciplinary and international. So we're representing the United States, Nigeria, Kenya, and we are actually addressing a local issue with a global lens, and we're being culturally sensitive about it. I'll hand over to Dr. Munawara Mohammed to continue from here. Thank
you. Thank you, Dr. Sarah. I'm Dr. Munawara. I'm joining from Nairobi, Kenya, and I'll be discussing the learning objectives and the problem statements. So for the learning objectives, by the end of this presentation, the participants will be able to understand the growing burden of type 2 diabetes in Karachi, Pakistan. They'll be able to identify key risk factors contributing to diabetes in underserved urban populations. Describe the Breaking the Sugar Cycle Karachi intervention model, explain the role of community-based screening and lifestyle education in diabetes prevention, and last but not least, understand the project's implementation, strategy, evaluation framework, and sustainability approach. Next slide, kindly. Okay, so for our problem statement, diabetes affects 589 million adults globally, with projections of reaching 853 million by 2050. The Middle East and the North Africa region currently accounts for 85 million cases, expected to double by 2050. So our discussion for today is the diabetes crisis in Pakistan and Karachi. Pakistan ranks amongst the countries with the highest diabetes prevalence globally. There's approximately 34.5 million adults who are living with diabetes. The national diabetes prevalence is at 31.4% among adults, and 9.3 million people remain undiagnosed. So the deaths annually are at 226,752 deaths. So why did we choose Karachi? Karachi is the largest city in Pakistan, and it's also the economic capital. So there are specific challenges that made us choose this city. These are due to the high rates of uncontrolled blood glucose amongst diagnosed patients. There is poor access to preventive healthcare and screening. There is low health literacy and unhealthy lifestyles. And lastly, there's rising diabetes complications. The community gaps we identified were there's limited community-based diabetes education, there's poor follow-up and continuity of care, there's financial barriers to healthcare access, and low awareness regarding prevention and lifestyle modifications. Next slide, kindly. Okay, so we gathered evidence from similar diabetes prevention programs that have already been carried out in Pakistan. They were done by United Diabetes Foundation and Pakistan Christian Diabetes Association, just to name a few. So the key lessons we applied in our project were community-based screening increases early detection, peer education improves participation and engagement, lifestyle education supports behavior change, community support systems improve sustainability, and lastly, strong referral pathways enhance continuity of care. That was my last slide. I'll pass it on to Unity. Thank you.
Thank you, Mona. Next slide. I'm Dr. Unity Johnny from Liberia, Monrovia. Next slide, please. Okay. The overall goal of our project is to reduce the burden of type 2 diabetes among underserved communities in Lari, Onga, Orangi, and Korangi in the district of Karachi. And we aim to do this through community-based awareness, promoting early screening, lifestyle modification, and finally strengthening linkage to diabetes care and follow-up services. Next. So to operationalize our goal, we have developed 5 SMART objectives, and they are: 1, we intend to deliver culturally appropriate diabetes education to 5,000 underserved adults in Lari, Orangi Town, and Korangi over the 24 months of our project, focusing on healthy eating, physical activities, early detections and prevention. Next, we intend to provide free community-based diabetes screening for at least 5,000 adults aged 35 to 65 during the project. And this screening will include HbA1c check, blood sugar check, blood pressure, and body mass index evaluation. Next, we aim for at least 70% of high-risk participants to complete a 16-week cultural adapted lifestyle program and show measurable gains in diabetes prevention knowledge, healthy behavior, and glycemic control within the duration of the project. And finally, we want to build and maintain at least 6 active partnerships with most healthcare facilities, community groups, community health workers, they are normally called the Lady Health Workers Network, to support long-term diabetes prevention, referral follow-ups, community health promotion by the end of the project. So I will pass over to Julie and I will continue next.
All right, so here we have the implementation plan. So this is the program framework where we screen, educate, and sustain. So the first step is we screen, checking their blood glucose, BMI, blood pressure assessments, diabetes risk evaluations. Then the second is we educate them. So we will do bilingual curriculum, which is English and having Urdu language, and also providing nutritional and physical activity education, medical or medication counseling, family-centered lifestyle coaching, peer educator and lay health worker engagement. And then the last one is sustain. So WhatsApp follow-up systems, mosque-based wellness groups, community peer support networks, long-term linkage to healthcare facilities. And we are targeting Lyra and Orangi Town and Korangi Town.
Our project relies on strategic partnership to strengthen our project relies on strategic partnership to strengthen sustainability, quality control. So we engage with few partners. We started with the Ministry of National Health, which is a governmental body, when it comes to formulating and regulating national health policy and also coordinating public health projects. So in this project, we aligned with the project with the national, we aligned the project with the national national non-communicable disease priority. They will provide policy guidance and coordinate the project as well and strengthen integration with national health strategy. We also contacted the Aga Khan University. They will serve as our academic and tertiary healthcare partners. They will provide technical oversight, clinical guidance, support training, referrals, and assist in monitoring, evaluation, and educational material. Next. We also have faith-based organization who will support the Pakistan Islamic Medical Association. They will support community mobilization and law-based awareness groups, engage in religious leaders and communities network. They will also deliver culturally appropriate health education. Lastly, the Diabetes Association of Pakistan. They are known for carrying on great projects in diabetes in Pakistan. We will also ask them for their expertise in diabetes awareness, education, training activities, provide technical guidance on diabetes prevention as well, and assist also in the educational materials, evidence-based interventions. Next. So I'll turn this part over to my colleague.
Here we have the theory of change. So this is the if, inputs or activities, and then the immediate and long-term outcomes. So if communities receive accessible diabetes screening, then we will have early detection of diabetes will improve. And also, if individuals gain culturally appropriate diabetes education, then diabetes awareness will improve and healthy lifestyle behaviors will increase. And lastly, participants receiving ongoing peer and healthcare support, then glycemic control will improve and diabetes complications and healthcare burden will decrease. So here we have the 24-month implementation. So we have the different phases, which list out to all the way to phase 6, the activities, and then the timeline. So in phase 1, we have the program setup, staff recruitment, partnership finalization, which is all the way from month 1 to month 2. Phase 2 is the training of peer educators and the LHWs. So that's from month 2 to 3. Phase 3 is community awareness campaigns and baseline surveys. So that's from months 2, 3, and 4. Phase 4 is screening camps and participant enrollment from months 4 through 18. Phase 5 is monitoring follow-up and WhatsApp engagement from months 18 to 21. And phase 6 is deadline evaluation and dissemination of findings from months 21 to 24. So it will be a 24-month long implementation.
Hi, everyone. I am Maria Chinyere Kane. We continue from where my colleague stopped. I am still joining from Maryland, America. So here we are talking about the expected outcomes. What do we expect? The outcome we expect. We divided it into short-term outcome, which we take up to 0 to 4 months, intermediate outcome, or we call it midterm outcome, and the long-term outcome. In these short-term outcomes, we are trying to reflect the immediate changes we'll expect to see once the program begins. We anticipate increase in diabetes awareness as people receive education and screening opportunities. We also expect that there should be improvement in their nutrition and their physical activities because the participants has been exposed to new knowledge and practical guidance. Then we also expect that screening uptake should rise and more individuals will actually name their diabetes status, which is very, very important, including their HbA1c, their glucose, their blood pressure, and their BMI states. So, and finally, we expect stronger participant engagement. As time goes on, they begin to build a lot of trust in the program activities. Then when we look at the medium outcome, or we call it the intermediate outcome, this one also represents a deeper behavior change when system strengthening. By this stage, participants should be able to adopt now healthier lifestyle practices more consistently, as unlike before. The high-risk individual will now have better follow-up, that they stay connected to care and support. The peer and the community support also deepens, network which also deepens and grows stronger. And we also expect to have improvements in early detection, referral for pre-diabetes and diabetes, as partners and communities work together in this program. Then the participants' lifestyle will show a lot of modification in their lifestyle as the awareness increases, and also there is trust increase in that. Then the last but not the least is the long-term outcome, and this long-term outcome reflects the overall impact of the program. What actually have we achieved in the program? We expect improved glycemic control among high-risk participants who stayed engaged with lifestyle changes. There should also be a measurable reduction in progression from pre-diabetic to type 2 diabetes. Then we also expect healthy lifestyle behaviors, which will become more sustained at the community level, not just individually. Then we also aim to see fewer diabetes-related complications and a reduced healthcare burden. Next. Now, when we come to evaluation plan, this is really the core purpose of our evaluation. We want to understand whether actually the activities we've been implemented are they producing meaningful improvements in awareness, behavior, health outcomes. We also trying to assess how well our community partnership and engagements supports the program has led us to success and sustainability of the program. We have some evaluation questions we need to ask. We need to ask some process questions and also the outcome questions. In the process questions, we are going to ask, our screening education section and lifestyle program delivered as planned? Are high-risk participants enrolling and completing in the 16 weeks program? And also, we are also going to ask a lot of outcome questions, which we say, has diabetes awareness increased? Are individuals learning their diabetes status? Do we have healthy behavior improvements, or has early detection increased and glycemic control improved? Next. Now, in this one, we are focusing on the methods and data collection. How do we collect our data and how do we analyze our data? Here, we have two mixed methods. We are going to use both quantitative and qualitative. Quantitative measures like the results, looking at the surveys. And when we talk about the qualitative and insight, we look at the interviews, we do focus groups and so on. So this approach now will help us to capture actually the measurable outcome and whether to know actually also the participants' experiences. And it will also help us to track program completion and partner engagement to ensure that actually our intervention is effective. The outcome and reporting, we expect results over time. Short-time outcome focus on awareness, as we have already seen, screen and early behavior. Mid-term outcome reflect deeper lifestyle adoption and stronger community support. Then our long-term outcome, we capture the ultimate impact of the glycemic control, the diabetic prevention, and finally, we are going to have reporting that will occur regularly with major evaluations at the midpoint and end of the project. I think I will hand over to my colleague to continue from where I stopped. Thank you. Next slide. Okay. The next slide is the staffing plan. This is our core team, core project team. We have a project director, which provides leadership oversight and donor reporting. We also have our project coordinator, which is among us, manages daily operations, logistics, and scheduling. We also have public health educators, which will be able to deliver diabetic education and awareness sections. And we also have lifestyle coaches, which will lead 8-week lifestyle program and support high-risk participants. And finally, in the co-project team, we have screening team, which is between 2 to 3, that will conduct HbA1c, the glucose test, BP test, and body mass index assessment. We also have some community monitoring and evaluation and support staff, which are to be hired from the community. We will have to hire a community mobilizer, 2 of them, that will be able to recruit participants and engage mosque, lady health workers, and community groups. We also have partnership liaison, which will be coordinating with healthcare facilities and strengthening our referral pathways. We also need a monitoring and evaluation officer, which will be there, which will lead data collection. We work with our monitoring and evaluation officer. This one is like an assistant, which will also help us to collect data, analyze it, and also report it. We are also going to hire data assistants, which will support us with data entry and database management. Then we have finance and administration assistants, which manages our procurement, finance, and admin task. And finally, we have the driver/logistics, which will support our transportations and equip movements and event setup. Thank you. Then my colleagues will continue and wrap it up.
Thank you. So I'll be continuing from the budget, and we made this budget with the mindset that we're looking at a high impact program that is going to be community-based and impactful. So we have our total budget is $200,000, and for the direct cost, it's about 57.5%, and then the indirect cost accounts for the remaining. So for the direct cost, there's the screening and clinical supplies. We're looking at getting about 5,000 HbA1c testing kits, and this will be used for people that have never been screened before. So that's about $55,000. Then for the education and training materials, we're looking at a bilingual curriculum, as we mentioned earlier, and then we're also going to get peer educators, and that's going to cost about $20,000. Then for the community outreach, you don't get involved in what you don't know. So we have to create awareness first for people to be aware of this intervention before they can actually participate, and that's also going to cost about $20,000. For the monitoring and evaluation, that's going to cost about $15,000. Then for partnership and stakeholder engagement, that's going to cost about $5,000. Then for the indirect cost, the personnel and staffing, we're going to get skilled, well-trained staff, and that's going to cost about $55,000. Operations and administration costing about $20,000, and then $10,000 for contingency. Next slide, please. So in conclusion, diabetes is not, it's a disease, yes, that can be prevented, but it's a preventable disease. But beyond being a preventable disease, BSc Karachi is here to address that problem. And with the right tools, communication tools, education tools, peer support, BSc Karachi is not just a program, it's a movement, and it's a promise to the people of Karachi that we're actually going to break the sugar cycle. Thank you.
Fantastic. Join me. Let's give group 3 some love. Let's show them some love. And I do want you to keep the slides there because we have questions. All right, we're going to go to the questions right away. First question, very important question. How can Pakistani cuisine be used to address type 2 diabetes?
Okay, so we noticed that Pakistanis eat a lot of white rice, and they take a lot of meat and lots of beverages. So we're not telling them to abandon their traditional food. We're just going to teach them how to practice portion control. Of course, they love to eat rice a lot. So instead of eating lots of rice, why don't they incorporate vegetables into it? And then we're going to advise them to take fruits, not the ones that would increase their glycemic index, like watermelon and the rest. Can look at others like cucumber. And then we're also going to also look at telling them to cut down on their intake of sugary drinks and beverages, and also reduce the oil that they use to make their food. I believe that that's a way.
You're muted. You're muted.
Yes, I'm done, sir.
All right. Okay. Good, good, good. So 3, all of you in this project are women, and you are going to a country that is predominantly Muslim, right? So only one Muslim woman. So how do you really plan to address the cultural issue due to religion?
Okay, so we're looking at having mosque-based wellness centers. So we have realized that a majority of people in Pakistan are Muslims. So we want to get to them through the mosque-based wellness groups. So we believe that they'll actually trust their mosques enough to expose them to the right tools and information that they need. So that's the angle that we're looking at. And then the Islamic Medical Association of Pakistan too. We're also going to partner with them to achieve that.
Unity, are you talking? Okay. All right. Good. The other one is, and this is my question, I observed that you have in your evaluation plan all qualitative. There are no quantitative information to say we project X% or X number. How are you going to address lack of quantification in your evaluation plan? You guys still there? How do you quantify your outcomes?
I think Dr. Chinyerem would be in the best position to answer that.
As I earlier said, I'm going to also combine it with, because we are going to use the key performance indicators in quantifying the evaluation. As I said, we are going to have three main evaluation plans. Let's go back to the slide, please. Can you get me the evaluation? Yes, so yeah. So as I earlier said, we are going to have data collection, and if we're able to get the data we use the data analyst or something, yeah, we'll be able to help us to quantify the data, give us the percentage of the outcome of the awareness, the percentage outcome of the attendance, and also the percentage awareness of those who did the qualitative interviews, something like that. So we are trying to focus on, or trying to see if the data we collected, we'll be able to use it to quantify. The baseline data, because we are going to do, first of all, the baseline data collection. Then looking at the baseline data collection, we also look at the endline data collection. Using both of them, we'll be able to quantify the percentage of the outcome.
Good. There's another question here. I think we have somebody from Pakistan who had indicated that in these 3 areas, Liari, Orangi, and Korangi, poverty is actually a major issue. Some people cannot even afford the food. So how do you, and you are setting up a program for diabetes, which is, and you are proposing interventions that is going to handle the kinds of food people are going to eat. You are saying eat vegetables, eat this, but these people cannot afford any meal. How do you plan to address that? Group 3, that's for you guys, Sarah, Chinyerem, and Julie, and Unity. That's for you guys. I'm not asking myself. Come on.
I think the best thing to do is, first of all, since we are working with the partners, with most of their partners and their health workers in their country, we'll be able to reach out to them and see if they will help. And then the little one they are eating already, we've helped them, as Sarah has already said. We try to let them know, even that little one they have, they can still make it, they can still use it in such a way that it will help them. But we are also reach out to some of these organizations so that they will help them with this poverty alleviation, because most of these people, especially those with high risk of diabetes, most of their meals or diets are very expensive. So we can also reach out to our partners and see how we can help them with that aspect. That's the way I look at it.
All right, another question. I see Ernest. Ernest is about to help you, with some suggestions. All the projects, all the partners that you want to have are all mosques. Are there no Christians in Karachi?
There are Christians there, but majority of them are Muslims, and that was why we actually decided to go through the mosque-based approach, because we even plan to recruit people from the mosque because it's a faith-based organization and it is something that they trust a lot. That's why we did that.
Ernest.
So I would just wanted to add that in countries where the poverty rate is high, you try as much as you can, like she mentioned, you create empowerment. And the second thing is for you to also limit out-of-pocket expenditure by creating health insurance as a policy.
Very good. Okay. How will you, somebody asked, we really want to know, how will you establish partnerships? What is your process? Walk us through your process for establishing partnership. And I guess this question is for all the groups, right? Because it's easy to say we're going to establish partnership with this, partnership with this. What is the process for establishing partnership? We're going to begin with group 3. After group 3, we have group 2. After group 2, we have group 1. What are your strategies, practical strategies for establishing partnership? Group 3, let's start with you.
Okay,
Group 1.
so
Okay.
Okay, so I feel like we'll start from recognizing groups or organizations that are already working on similar projects, like now the Diabetes Association of Pakistan, writing to them and telling them about what we want to do and seeing if we can get some support from them. Well, I believe that that's a good place to start. Dr. Unity can continue from there.
Yes, so for the partnership, I think first we have to map stakeholders who are going to be involved with the project. And then we try to form engagement meetings with them, signing documents, memorandum of understanding how we'll be done, engaging with community leaders.
Very good. So I got map stakeholders. In other words, you identify who the potential partners are going to be, cold emailing, right? And then you're going to have engagement meetings and signing of MOUs. Group 2, what else? What else? What are some of the practical strategies for establishing partnership? You are based in the United States, or you are a US-based organization and you are going to this brand new country. What is your strategy for establishing partnership? Group 2.
I think group Unity have said what I was
We
having
shouldn't be
in mind.
beginning with I think. We should be sure of
Okay,
what we're saying, right?
okay. I think okay.
I think.
Unity like said what was in my mind, because I know that we have already in the process of writing our grant proposal. We have identified the groups that we want to partner with. So the next move is to reach out to them and see their availability, and then and see if they will accept to partner with us. If they do that, then I think the next step will be to arrange for a meeting where we go and then we discuss our agenda, what we have for the group, for what we want to come and to do. And then at the end of the day, just as they said, sign necessary document, and then we kickstart.
Perfect. Okay. There is something missing. Group 1, there is something missing in partner identification.
Well, just to add, after identification, contact initiation, the next is to build trust. You need to build trust with your partners. You also need to define your shared objectives. You need to have shared objective, and also you need to collaborate in your implementation plan.
Okay. All right. So I'm going to add one thing, and then I'm going to pass it over to Dr. Armstrong and see whether she has some thoughts. The primary thing that you begin is networking. That is the most fundamental thing that you do. If I'm going to do a project in Nigeria, I'm going to ask, who in my network is from Nigeria? That's the beginning, right? Because we know that cold emails, they say less than 3% of cold emails, people respond to them. It's like you receive an email from a stranger. You don't know who they are, asking you for partnership. There is a lot of online fraud now, people masquerading to be what they are not. So you're not going to get a lot of response there. But if you were to be on LinkedIn, if you were to establish your reputation on LinkedIn as a professional, that network is going to be the beginning. So I'm going to ask, who is in Pakistan? I say, oh, Bushra is in my network. Bushra knows me, right? There is a relationship. She knows me. If she sees my email, if she sees my message, she's going to recognize me because I'm a human being. She knows who I am. And then Bushra will now leverage her own network because she's a physiotherapist. She has an office. She has a business. She will say, yeah, I know somebody. You need to reach somebody in Diabetes Association of Pakistan. You reach this person, right? You reach this person. If I'm doing something in Kenya, I'm going to reach out to Munawara and say, Munawara, I want to do this. Can we talk? Munawara knows me. She will respond. So the power of personal relationship and networking is the foundation for making useful and workable relationship. Dr. Armstrong, I'm wondering, what else you have, and Dr. Murillo, please weigh in too.
No, I think you've touched on it. Usually with this kind of thing, you want to create what we call a stakeholder analysis, right? So you're trying to brainstorm who your potential stakeholders are, who your potential partners are. Do they share the same goals? Do they share the same, what are they looking for? In addition to all the other things that have been said. So I think I'll settle I will rest my case here. You've touched upon it adequately.
Great. Dr. Murillo, anything to add?
Just that there are many potential partners with established areas of expertise, and I think I asked a question of Group 1, and in there I identified some of the people that you could ask to partner with. And let me go up there and see. It was in the comments. Multilateral organizations, government health agencies, private foundations, regional funders, academic research institutions, and if you're using online intervention, digital health specialists.
Fantastic. All right, this is great. Thank you so much, Group 1, Group 2, Group 3 for proposing excellent interventions. I think these interventions, each of them is shovel ready. The next step will be for you to take in the feedback that you have received today to improve your slides, improve the documentation before you do the submission, and then to write the full abstract that is going to be published on GHEP website. Remember, we are not all talk. We want people to see. When we tell them we did this program, we want them to be able to see what is the outcome from the project and the deliverable. I am going to call on Dr. Zubi, who is going to tell us the scores for the Best Project Award. She's going to tell us what the other people have scored, and then we are going to announce that and we are going to adjourn. But before we do that, while she's doing, Dr. Zubi, are you ready? Or do you need a few more minutes?
Few more minutes, please.
Sure. Okay. All right. So we are going to take a couple of observations now. You've been on this 3-month journey with us. You've had a lot of opportunities to outreach, a lot of opportunities to create interventions, and you've heard from our excellent guest speaker today. I want to hear from you as you are leaving this program, as you are graduating this program. What are the top 3 things that you plan to do? I'm going to call if you don't want to volunteer. Temesgen, we start with you. What are the top 3 things that you have on your schedule for the next few months? Short term, long term. What are top 3 things that you plan to do with all the knowledge you have acquired in this investment for 3 months?
So the top 3 things currently I'm planning after this session is number 1, I will search for government jobs in my city, and then I will apply, of course. Then I will be ready to bring my knowledge to help my community that I gained from this program. Since this program is a hand-on program, it's we had a theory. I've been in a public health school for the last 2 years, and then it's all theory. And then this time I gained a lot of skills, lots of hand-ons. Like we did this project, we had another project before from this, and then those all are helping me to how to implement, how to design a program. how to use PDA for certain cause or some problems in like it could be existing or it could be new problem that happened in a city. So I can use my PDA knowledge and then come up with a solution. That's my plan.
Perfect. Very good. That's really very precise. Start pursuing jobs in the government. I remember you have a resource from Public Health 360, an HR specialist who you still have opportunity to consult for the support that she's going to provide to all of you as part of your programming. Who is next? Comfort.
Okay, my three plans that I have. First of all, the project I worked on has opened my eyes to see that sometimes the student I work with, because as I shared before, I have a mathematics club that online I do lesson with them. So sometimes students are not participating the way you expect. You may be thinking that they don't want to, but probably they're going through some mental stress and issue. So this has opened my eyes to look at these students as people who may be going through some kind of mental stress that I need to reach out to them. That is one. Two, it has born in me the passion to work with organizations that work for the development of areas in Africa or developing countries. So I contacted online who. So I went to WHO website to see the possibility of me volunteering to work with them because of the knowledge, the knowledge I have gained from this program. So, but at the moment, like they're not admitting students yet for volunteer services. So that is one, two. So the third one would be like what now? The third one, I'm trying to see how I can incorporate a curriculum in what I'm already doing with my student that will help with their mental something like counseling and all that.
Very good. Okay, that's very good. Dr. Sarah Ayeni, what are one or two things that you plan to do? Keep it short because we need to move around until Dr. Zubi is ready.
Okay, so the first thing I want to do is to actually pursue a career in program management. This fellowship has exposed me to more leadership roles, as I was the project director of our outreach and even this capstone project. So that's something I want to pursue. I also want to improve more on my communication skills. That's something that this fellowship has also, and then another thing I want to do is to develop my adolescent, because I am an adolescent health enthusiast. So I'm also planning to develop a GO that is tailored towards decreasing stigmatization and also increasing their access to sexual and reproductive health services. So yeah,
very good, very good, very good. Precise. Ernest.
Okay, for me, the three things that I would like to develop on is first, I will review my learnings, all the things I've learned in the class. I'm going to review them. And I'm also going to improve my LinkedIn so as to get more network. Then the last one is I will now start acting like a professional.
You shouldn't be acting. You're a professional. You shouldn't be acting like one. Okay, very good. Tinyerem. You're muted.
Yeah. So I am so much excited for the completion of this course. As I earlier said, somebody who is coming from the background of a material scientist who have been doing research in breast cancer, which I have always been focusing on the lab. So, but this course has really taught me to see the breast cancer with another lens. See it with another lens. See it with another lens, trying to see how I'm going to start community-based intervention, especially with breast cancer reduction in my locality or in the convent, actually, not really in the local, at least be able to do some awareness, educate people on how to reduce the incidence of breast cancer, as somebody who has been working on breast cancer for a long time in the lab.
Yeah, thank you. So you have an opportunity now to translate from basic to clinical, basic to public health, to get a firm understanding. Very good. Okay, moving on. Next one, who do I have on my list? Sarah Catesby.
Yeah, thank you. Yeah, first of all, I want to just say thank you so much, because this program has been such an eye-opener. I'm leaving feeling empowered. And another thing is, when I started, it just inspired me to look into MSc, which I've already been enrolled with Brunel University London to study global public health and social justices. I've got a dream to one day work with the UN. So I want to work in Africa. I'm from Kenya originally, and I want to work there with developing countries, you know, dealing with social injustices. So I'm so grateful for this. Also, this will help me towards registration with UK Public Health Registrar. So this is gonna go into my portfolio. It takes a long time once you finish university to be able to go through the registration, and this will help me towards that. But I must say this has been the best course I've ever been into. I feel empowered. I came feeling, oh, I don't know, but now I feel like I could stand anywhere and just, you know, yeah. Thank you.
Congratulations. Excellent, excellent, Sarah, excellent. Bushra, where are you, Bushra? Come on.
Thank you so much, sir. Three things I learned from this course is, first, I learned that the most important thing is networking. And I'll work on my LinkedIn and I'll network with the local people and internationally to meet what I want to do in my community. Like, I want to reduce the increasing rate of non-communicable diseases due to sedentary lifestyle. So I want to work on that. And secondly, I want to bring physiotherapy practically into every household and every person that is not well aware of how physiotherapy works and how it is important for them, and work with different government organizations to make it accessible for them. And thank you so much. This program has changed a lot and brought a huge confidence in me.
Thank you so much, Bushra. Thank you. Looking forward to partnering on those. Julie Hur. Julie, where are you, Julie? The brave soldier is Julie. Where is Julie? Where is Munawara? Munawara, where are you?
Hello, I'm here. Okay. Three things I've learned from this program. The first one is, I think it has changed my perspective from a clinician to a public health fellow. So after this, I would want to apply for opportunities in the NGO world, in maternal and child health. And secondly, I've gained confidence in this program. I feel like right now I'm more confident in my ability to design a project, implement it, and see it through. And lastly, I want to improve my LinkedIn connections, first of all, with all the fellows and the faculty, and that's it.
Very good, very good. Unity, where are you, Unity? Then Miriam. Unity, where are you? Come on, Unity.
Yes, so thank you so much, Dr. Rome and team, for all you have done for us over the 3 months. It was great. And what I've learned from your team, the level of dedication, there were times I almost gave up because a lot of other things, but your team was supportive. Colleagues who I work with also kept supporting me. And I'm engaged in community art health, but I was not comfortable with project management, but this program has taught me at least how to manage a project, how to write proposals. So I think I'm going to apply to my day-to-day career. And my LinkedIn too, I've been on LinkedIn, but it has just been there, not active, but you kept on telling us to activate our LinkedIn account. So from today, I'm going to be active on LinkedIn so I can keep connected. Thank you again for everything. And I will, if you ask me, I want to do this course over and over and again because it was nice. It was nice. In 3 months, I could grab something.
Look, we have a lot of doctors in this cohort, right? What we need you to do is to go and change the world, right? As clinicians, you are trained one patient at a time, right? Bushra, one patient at a time, one family at a time. But now you have all the skills, you have all the knowledge, you have all the aptitude to be able to really take that to population level. So that's what it is, you know, for all of you doctors, even a material scientist, this is now taking the lens to a population level, you know, through which you see problems. Remember, you have the skills. I need you guys to make money so that you can donate to GHEP. I need you guys to be consultants. I need you guys to charge people money. Remember, I'm telling you that public health is not free. You charge people money when you provide skill-based things to them. You volunteer, but then you charge them money because you are experts. Right? We don't pay, we don't give free service. We volunteer, we deliver our services, but we charge money for our skills, right? Marilla is going to tell you how much money they are paid to go to school. It's not cheap. Going to school is not cheap. So you got to charge money to be able to get that money. And I saw a number of our alumni join us. I saw Dr. Mazia Jaffrey here. She's doing great things. I saw other people. I saw a lot of names that I recognize who have joined us. Come on, Miriam, you are in Kuwait. Miriam, tell us, how much has this changed you? What are you taking home from this project? Miriam, come on. Where is Miriam, the doctor to be? All right. Dr. Zubi, you are ready with the big news, right? We are ready with the big news. Which of these 3 projects, these are already excellent projects, but which of them emerged the best? While we're waiting for you, let's allow CJ, Dr. CJ popped in to introduce himself. He is our partnership director and our policy one. Dr. CJ, do you want to introduce yourself?
Hi, everyone. I'm Chidubem Eboluche. I'm a doctor of public health student at Morgan State University, and I'm also a center director with Southern Maryland Tri-County, where we provide various social services, including, you know, energy assistance, housing assistance, emergency food, name it, CDL training, workforce development, and we serve the rural community in the Southern Maryland. And, you know, as public health person, as I'm mentioning this, you'll be thinking social determinants of health, right? And I'm happy to be here with you all. And yeah, I wish you all well in your graduation. Go and do something great. Do something great.
Thank you so much, CJ. Thank you all our guests for joining and for sticking with us. We really appreciate you. I saw a question and that question was answered. All the graduates today are going to receive a certificate of completion, right, for this program. In addition, they will have to maintain, you know, they have access to a continued affiliation with GHEP. And that is because we know them, they know the organization. That's another one. And then those who are in the group that won the best capstone award today are going to get a secondary certificate for this project. I think this is a way to incentivize, programming, incentivize leadership, incentivize followership, incentivize critical thinking, and ensure that when you are living here, you are living with a lot of knowledge. Remember, imposter syndrome is the truth, right? It exists, but you got to kick imposter syndrome out, which is that little voice that tells you, oh, you're not good at this. You already know that you are good at this. You only need to emerge and begin to serve in your community. You have all the tools. We're going to create our LinkedIn group, and in that group, we are going to create a community where you can tap in and have resources from each other from all parts of the world where you are. So I want to open it up for any of our alumni or any of our guests who just want to make a brief remark, and then we give it to Dr. Zubi to announce the results. Anyone? Any takers? 1, 2. Dr. Mazia, okay, you want to talk. I see you.
You can unmute yourself. You're muted. Okay.
Good day, everybody. And thank you, Dr. Romay. Thank you, Dr. Suzanne and others. It was a great session. I enjoyed. And between my staff, I was listening, and I had some difficulty issue with my computer as well. As a alumni, I can say that it was a great experience that I had during my session with the Public Health 360. I'm gonna start my residency in July in family medicine. So this public health and this project empowered me in many aspects. First of all, in the patient education, because our project capstone and the community outreach was based on the educational awareness between the population. So I can use those experience in educating my patient. The other thing is the prevention and the population health perspective. All the project that Public Health 360 works on is a public health issue, actually. It's no matter it's a sickle cell, it's a diabetes, it's a obesity around the world, specifically in the United States and other places. So knowing how to find the problem as a public health issue, how to work and which community you need to reach out, you can get a good result. So other experience you can get during the work with the other team member all the time, because everybody comes from different background, different experience, different cultures, and they have their own perspective, and all together you can provide the best for your project. And the last thing is interprofessional collaborative and the community engagement. This project is, I learned that our job is not just from our side. It's a two-sided work. So my group in the one side, and the community is the other side. So if we can engage and communicate professionally and effectively, we can get the good result. That's all my takeout from this amazing project and the amazing 3 months education and training. Thank you.
Thank you so much, Dr. Jaffrey. So excited you'll be doing family medicine. I hope I can see where you are. Maybe you can be our doctor. Very good. I love it when doctors say my patient, right? That the nurse in me, I remember those, you say my patient, right? Which is great. And Dr. Blankson also did family medicine. I hope, Dr. Blankson, you can consider joining us in the next cohort. So the summer program is going to start imminently. The program is, remote, but it's intensive, but we have our product. So I'm going to hand over now to Dr. Zubi, who is going to announce the winner, and she's going to talk a little bit about the process also. Dr. Zubi.
I will allow Dr. Murillo to make a comment because his hand is up.
Oh, Dr. Murillo, sorry about that. Go ahead.
Yes, Dr. Azwini. I would like to take this opportunity to ask if we can have a meeting, because I have 2 projects that I would like to propose to collaborate with you and your rich fellows. Specifically, it's from my recent Master of Arts degree in Human-Centered Artificial Intelligence, which I received 2 weeks ago, where I learned how avatar-based communication can help reduce public health disparities. So 2 projects I'm considering real briefly. How can human-centered artificial intelligence help reduce Ebola risk in the Democratic Republic of Congo? How can human-centered artificial intelligence help reduce hantavirus pulmonary syndrome risk in Latin America? These are endemic in those countries. So please, would like to talk with you soon.
Sure. Congratulations. Excellent. Cutting edge. AI, right? Cutting edge. We're going to convene. We're going to strategize. Sometimes I procrastinate. I've been procrastinating creating this framework, but it's imminent now. And I welcome you to really helping us create this, this partnership where you have individuals from across the world. We just want to make sure that we do it right so that people are also compensated for the work that they are going to do. So I'm going to send out an email. There is also another of our students who wants to create an online course that she's going to co-create. So people, ideas are coming on. We just need to, create a fertile ground for it, and so that we can get it going. Thank you so much. Excellent. Any other person want to talk?
I think that's it.
Great. Excellent. Excellent. All right, Dr. Zubi, over to you now.
Thank you. Thank you, everyone. We did great. I would like us to use this moment to give ourselves a round of applause for you to stay here from the beginning till the end at this hour. You all did great, from the guests, family, friends, and all of our graduates today. Everyone is so excited. I can see the smiling faces. I mean, I can't even contain it, but we are so grateful for all of you. You learned a lot. I learned a lot from you guys, and you guys are doing great. And for us, the presentation today, all of them were strong. You guys did a great job. The professionals here can testify. And you are already getting some contract deals to come and participate in a project. Isn't that great? That is awesome. Thank you, Dr. Murillo, for the opportunity. And I know our graduates are really excited, ready to take on this opportunity. And for us to go into the winner of today, all of us are winners. I want to establish that. Okay, all of us are winners, and we did great in our presentation. But guess what? One person have to do what? Or one group will still emerge as the winner. And just to go over the scoring, how it went, we looked into the, whose presentation, different criterias, identify your group, if you guys were able to identify important global problem and target population. We also looked at, if you use evidence and database to explain your problem matter, propose a realistic and appropriate solutions, programs, policy, or intervention. Okay? Did your program or your presentation address equity, ethics, culture, and community context? And also, if you were able to include a clear implementation and evaluation plan with measurable outcome. I remember Dr. Romy emphasized on SMART, measurable outcome. So those are where our criterias, and I want to tell you, all of you kind of touched each and every one of these, but some explained it well, some gave detail, so in that, and the overall, based on all the things we gathered together, I want to call from the third position, which is Group 3. They emerged with 18.6 score. Please, can we give them a round of applause? Because they did great. Professionals, we are so happy. Guests, we are happy, asking different questions. I was so surprised because, they worked on this project within a very tight time frame, and they worked as a team. And the second position came to group 2, 18.8 score, which is really shows a strong presentation today. I mean, they did a great job. So you guys should be so excited. And can we give a drum roll? Drum roll for the best, and the winner of today's presentation is group 1, came in with 19.5 score. Please give them a round of applause. And also, great job and congratulations to all of our graduates today. You guys did a great job. Thank you, Dr. Romy, for this opportunity. And thank you all for supporting our graduates and for this great work.
Congratulations to all of you. Group number 1 for emerging our spring 2026 best capstone project. So you are all going to receive your regular certificate, and then you are going to receive an additional certificate. And I hope all those things that Brown taught you about LinkedIn, you're going to go straight to your LinkedIn, update it, and get it going. Congratulations, everybody. And, it's 2:16 where I am. Thank you all for sticking here. Thank you for all family. Thank you for friends. Thank you for colleagues. Thank you for everyone who saw this ad online and joined us today. I hope spending your 3 hours with us has been rich. We are looking forward to having you, having friends, having family. Please help us continue to grow this program by telling your friends about this program, by transforming communities where you are. That is the most important thing, right? You are addressing disparities, you are changing lives, you are changing communities, you are changing families. Congratulations, wishing you all the best. And do not be a stranger. Look out for communication from us. Look out for invitation to join the group, and look out for us to convening into project groups. That's what Dr. Murillo is pushing us now. We gotta push ourselves into interest groups, maternal and child health, AI, and so on. We have the team. We're gonna conceptualize that work and reach out to you. Congratulations, and that's it. Brown, do you want to sing us out? Looking forward to connecting again, ladies.